Shall I start sharing my screen?
Yes, ma'am, you can start.
Yeah. So very good morning to all the participants of this very interesting Diagnostic Week CME. At the outset, I'd like to thank the Melap Foundation and Dr. Neeraj Jain sir for giving this opportunity and for organizing such an interesting CME. So I'm Professor Purvi Purohit from Department of Biochemistry, AIIMS, Jodhpur, and I'll be talking today about the laboratory management of diabetes and its complications. So the roadmap for today's talk would be, we will be initially talking in brief about diabetes, what it is, its classification, how diabetes is a formidable foe as it's affecting the healthcare infrastructure, the role of diabetes, the role of laboratory in management of diabetes, the screening of diabetes mellitus, the laboratory diagnostic investigations for diabetes mellitus, the laboratory tests for assessing the long-term complications of diabetes, and the laboratory tests for acute complications of diabetes mellitus will be taken up. And finally, we will be looking at certain miscellaneous investigations. Now, all these investigations that we will be talking about would be discussed in correlation with the guidelines, the current guidelines that have been given by ADA and by ICMR. So, as we all know, diabetes is a group of metabolic disorders of carbohydrate metabolism in which glucose is both underutilized and overproduced, and it results in hyperglycemia. Having said that, the hyperglycemia can result due to either the absolute deficiency of insulin, or it can be because of hyperinsulinemia but insulin resistant state. And therefore, if you classify diabetes, it is broadly classified into 4 different categories. Type 1 diabetes is the first one, which is an autoimmune condition, and it is seen in almost about 10%. Mostly, it's seen in young age, in children, and in adolescents. It may have an immune-mediated ethiopathology, or it may be an idiopathic condition. Predominantly, there is a pancreatic beta cell destruction in type 1 diabetes mellitus. In type 2 diabetes mellitus, which is much more common as compared to type 1 and the other specific types of diabetes, this is the state where you see hyperinsulinemia and insulin resistance. Then there are certain specific types of diabetes where you see genetic defects of beta cells, or you see genetic defects in insulin action, the diseases of exocrine pancreas, various endocrinopathies leading to diabetes, drug-induced or chemical-induced diabetes, or it could be various infections which eventually can cause diabetes, and there's some certain uncommon forms of immune-mediated diabetes and some genetic syndromes that eventually are associated with diabetes. Then the crucial one, that's gestational diabetes, which is seen in the pregnant mothers. Now, diabetes mellitus is a formidable foe, and India is the diabetic capital of the world. According to an estimate by IDF, the worldwide prevalence of diabetes was almost 537 million in 2021, and it was forecasted to reach almost 783 million by 2045. The picture for India is as bad as it is globally. So in India, there were around 74.1 million diabetics in 2021, and this is projected to rise to almost double, 134 million by 2045. And the sorry state of affairs is almost 45% of diabetics are undiagnosed. Because of the increased number of diabetics and the large burden of the undiagnosed diabetics, this number poses a lot of economic burden on the healthcare infrastructure. And there was a very famous news clipping in Times of India last year, and it said that diabetes is bleeding the Indian healthcare infrastructure. And it was estimated that in 2017, almost 31 billion US dollars was spent in India alone for the care of diabetics. And this was not just fancy figures. There are multiple studies that have been carried out across the country. And all these studies have calculated the direct cost of diabetes in India in those specific regions, as well as the indirect cost. So both, when you talk about direct and indirect cost, it means direct cost is when there is the expenditure for hospitalization or medication or any investigation of the diabetics. And when you're talking about the indirect cost of the diabetes, then it is the man hours that are lost by an individual in his profession due to absence because of hospitalization of diabetes, or the reduced work efficiency of an individual due to diabetes. Thus, there is a lot of economic burden that is caused because of diabetes. Now, we Indians, yes, we know that we reside in the diabetic capital of the world, but then we have an Asian Indian phenotype, which makes us highly prone to conditions like diabetes. Why? Because we've seen that we have a lower threshold for BMI. For diabetes, we have anyways a higher level of insulin, and we develop insulin resistance much quickly. We have a higher abdominal obesity and visceral fat. Our levels of adiponectin are higher, the inflammatory markers are higher, and all these together contribute to an increased prevalence, not just of type 2 diabetes, but also its long-term complication like a premature cardiovascular disorder. So where does the role of laboratory come in management of diabetes? It comes at different levels. The laboratory can help in screening the diabetic population. It can help and facilitate the diagnosis of diabetes, monitoring of the diabetes, as well as assessing the long-term risk that can happen due to diabetes in the form of various micro and macro angiopathies. So the further discussion from here would be discussed in terms of comparison of these two guidelines. The first set of guidelines is the guideline which was, this was a guideline that was given by an expert group. And this expert group gave their recommendations for the various investigations in diabetes management in terms of the evidence that was available, in terms of the various research evidence that was available, and they scaled their grading or their recommendation as high, moderate, low, and very low recommendation. And if you say that there is a high recommendation, it means that further research is unlikely to add to our confidence. That means one particular recommendation which is at higher grade according to this guideline, then additional research would not add to its value. It anyways is a proven fact. Other grades of moderate and low can indicate that there is greater need of further research, and further research will help us build on the evidence which is already existing. And so depending upon the amount of evidence that's there, the moderate and the low grades are made as the levels of recommendations. And finally, there is the very low recommendation where the evidence, even if you do a lot of research, some of the investigations are actually obsolete and they may not be done at all. Even after conducting a lot of further future research, it's not going to add to our evidence at all. And therefore, they should be left out. This was given in 2023, and it is also getting support from AACC, that's American Association of Clinical Chemistry, and it's also getting acceptance from ADA. The other set of guidelines are the guidelines that were given by ICMR for management of type 2 diabetes. So wherever relevant, both these guidelines will be discussed simultaneously henceforth. Now, when we talk about screening of diabetes mellitus, the guidelines and the recommendations that were given in the year 2023, they recommend that screening of all adults greater than 45 years of age should be done using the fasting plasma glucose, and it should be repeated every 3 years. This has a moderate rate of gradation. Then the screening is also recommended in high-risk individuals of diabetes, and it can be done using either fasting plasma glucose, it can be done using HbA1c, or it can be done using the oral GTT. But then you can simply do the short form of GTT where you take the fasting sample and the 2-hour sample post-glucose load. The good practice point is a recommendation which is given in this guideline where they say that having good recommendation, good practice point means that it would be good if you could execute this particular set of recommendation. So here in this screening, they suggest that the laboratory which is testing for screening of the population should ideally be an accredited laboratory. But this is not something which is mandatory or takes away from the value of other laboratories not accredited. But they say that it would be a good practice point to have an accredited laboratory for the diagnosis or screening of diabetes. So when we talk about the ICMR guidelines, they also give their set of guidelines for the population which should be screened. So in the earlier slide, we saw that the recommendation by the ADA group, expert group, is about 45 years of age. But ICMR in India suggests that the screening should be performed in all the individuals greater than 30 years of age. And it should be carried out at an earlier age in the adults who have a high risk. When we say high risk, it means that a person who has a family history of diabetes, if an individual is obese, or if has a higher waist circumference, having a history of hypertension, dyslipidemia, has a sedentary physical lifestyle, if there is a history of gestational diabetes, if there is a history of cardiovascular disease or polycystic ovarian syndrome and acanthosis nigricans. So these are the high risk populations which have been identified by ICMR. And these are the population which should be screened earlier. That's just after 30 years of age. Now coming to the lab diagnosis of diabetes. Now, lab diagnosis of diabetes includes two investigations. It includes the urine analysis and the blood analysis. Now, we all know that urine analysis is a simple dipstick test where you simply dip a urine testing strip and you get the various parameters like sugar, protein, blood getting reflected in a semi-quantitative way. Blood analysis is you can do investigations like fasting plasma glucose, you can do HbA1c, or you can do the oral glucose tolerance test. Now, coming to urine glucose analysis. Now, urine glucose analysis can be done by Benedict's test, or it can be done by Clinitest tablets, or it can be done by the strip test, as I just mentioned. And we have been doing this right since our undergraduate days. But the guidelines for the urine analysis, the recommendation is low. It is not recommended for the routine care of patients with diabetes. It may be a test where you can randomly just check for the presence of glucose, but it does not help in any way in monitoring, diagnosis, or the routine care of the diabetic patients, and it should not be used. Coming to the diagnosis of diabetes, now we are all aware that the diabetes diagnostic value for the fasting plasma glucose is greater than 126 milligrams per deciliter. And the guidelines and the recommendations given by David Sachs and his expert group also support the same. They say that the fasting plasma glucose greater than 126 mg per dl is diagnostic of diabetes. In addition to that, if there are any symptoms of hyperglycemia and a casual plasma glucose of greater than 200 mg per dl, that also can be used as a diagnostic marker for diabetes. Plus, you can perform the oral GTT for with 2 hours plasma glucose having greater than 200 mg per dl. That's also confirmatory for the diagnosis of diabetes. And standalone HbA1c greater than 6.5% is also a diagnostic criteria for diabetes. Now, in the ICMR guidelines for the management of type 2 diabetes, the diagnostic criteria is very much similar. ICMR also recommends values greater than 126 mg per dl in FPG greater than 200 mg per dl in the 2-hour post-glucose load, 6.5% HbA1c or more in diagnostic of diabetes, and a random plasma glucose. So here ICMR matches exactly the recommendations of the David-Sachs group. So how do we estimate blood glucose? We estimate the fasting blood glucose after an overnight fast, preferably 8 hours fasting. And a postprandial blood glucose is usually collected at 2 hours after the subject has taken a normal meal. A random sample may be taken at any point of time during the day, irrespective of the time of meal. The sample which is preferred is a plasma sample. When it is a laboratory investigation, we usually prefer a plasma sample, but if it is a home testing device like a glucometer, a capillary blood sample is also used, but then with a caution that the capillary blood sugar would be almost 5% higher than the venous blood sample. So there are some common interferences which can be seen in glucose estimation by glucometers, which include the environmental conditions like high altitude, temperature, humidity. All these affect the blood glucometer's accuracy and efficacy. So research shows that there may be an elevation of about 1 to 2% under estimation of the blood glucose with your altitude or higher temperature or humidity. Along with it, if a patient is taking paracetamol or eating food with high levels of vitamin C or maltose, that can also give a false hyperglycemia results. So when a sample is collected for laboratory investigation of blood glucose, very fundamentally, we all are aware that the sample has to be collected in a sodium fluoride EDTA tube. Sodium fluoride alone is not of use. Besides this, the sample should be spinned, plasma separated within 15 minutes. And if not, then the sample should be kept in an ice slurry or in a citrate, along with the citrate buffer. And it should never be kept at room temperature, because at room temperature, there's a drop in the blood glucose at the rate of 7 mg per dl per hour. So you'll get a false low values. Coming to the next investigation, that's the oral glucose tolerance test. Now, oral glucose tolerance test is not used, not recommended by ADA for a routine diagnosis. However, WHO does recommend its use for for those individuals who have an impaired fasting glucose. That's the fasting plasma glucose between 110 to 125 mg per dl. They are the candidates for OGTT, or in the patients of gestational diabetes. And we are all aware of the method of glucose tolerance test. And so I won't be repeating all that detail, but yes, the test can be done as a 2-hour test in adults with 75 grams of sugar. In a child, if you are to perform it, then its value is 1.75 grams of sugar per kg body weight of the child. And if it is to be done in pregnancy, then it's 100 grams of sugar. And the samples are collected, extended till 3 hours. So when do we do OGTT? It's done in asymptomatic persons with sustained transient glycosuria, or in patients with symptoms of diabetes, but no glycosuria or hyperglycemia. It can also be done in patients who have the family history, but do not have any symptoms or any positive blood findings, or in patients with or without symptoms of diabetes, but do not show any kind of, or show just one abnormal glucose finding. Then you want to be sure and you do an extended OGTT. Then in patients with neuropathies and retinopathies of unknown origin, and the person is undiagnosed for diabetes or hypertension, then you would want to check for the OGTT level. OGTT can also be done under special conditions where you want to check the pre-diabetes or latent diabetes using a cortisol stress test, and or an extended one when you want to see the cause of hypoglycemia. Many times that you might get an individual who's complaining of severe hypoglycemia post meals. So you would do an OGTT and do an extended OGTT for almost 3 hours after the load and check when the blood sugar is critically dropping. Now, for gestational diabetes, these are the recommendations by the David-Sachs group for GDD patients, GDM patients. So it can be done as the 75 grams OGTT sample, where you collect the samples at fasting, 1 hour, 2 hour, typically done in the pregnant mothers at 24 to 28 weeks of gestation. It can also be done with a 50 grams of glucose load in a non-fasting state. And if it is done in the non-fasting state with 50 grams of glucose, and if the 1 hour sugar is greater than 130, 135, or 140 milligrams per deciliter, then again an extended GTT with 75 gram OGTT is done. The target values, which are given here, they match with the International Association of Diabetes, Diabetes in Pregnancy Study Group, that is IADPSG. And these are the target values which should be followed. Now, women with gestational diabetes should be tested for pre-diabetes or diabetes 4 to 12 week postpartum as well, using the non-pregnant OGTT criteria, because these women many a times may not get resolution of the diabetic status even after the termination of the pregnancy. And therefore, the David Sachs group suggests that the women with GDM, they should be screened for pre-diabetes or diabetes at least 4 to 12 weeks postpartum, along with a lifelong screening of diabetes to be done in these women with a history of GDM using a standard non-pregnant criteria at least every 3 years. So every 3 years, this screening should continue. Although there is this guideline came in 2023, and they said that there is a lot of studies going on whether the screening should be done before 24 weeks. And very recently, in February, DIPSI, that is the Diabetes in Pregnancy Study Group of India, they have started recommending screening of GDM at as early as 8 to 10 weeks of gestation. So that's a new update on this. Coming to the next very interesting investigation in laboratory, that's glycated hemoglobin. Now, glycated hemoglobin was first of all defined in 1994 by IFCC, and they said that it's a fraction of HbA0 that's glycated non-enzymatically at the N-terminal end of beta chain. Now, why should we measure HbA1c? Anybody who's studied biochemistry or even studied the basics of MBBS, they should be aware that HbA1c is the glycated form of hemoglobin A1, and its formation is irreversible. So once your HB gets glycated, it does not get reverted, and it can be used for monitoring of diabetes. And when you get a percentage of HB, say 6%, 7%, or 8%, it means that out of that 8%, 50% is of previous month, and 25% reflects almost 2 to 3 months previous data. And this HbA1c reflects your lifespan of RBC as well as your glycemic control. It can also help you determine the estimated average blood glucose in mg per dl using this formula, 28.7 into A1c minus 46.7. So these are the current recommendations for a good glycemic control. IDF says less than 6.5, ADA says less than 7%, and the American Association of Clinical Endocrinology suggests less than 6.5%. Now, HbA1c is a very, very important investigation for diabetics because it was reported way back in 1996 by the Diabetes Control and Complication Trials that the microvascular complications of diabetes increase as there is an increase in the percentage of glycated hemoglobin. And you can see in these two graphs that as the percentage of HbA1c is increasing, so is the percentage of individuals with the risk of retinopathy and microalbuminuria increasing. But then there are potential pitfalls in HbA1c assay, and the questions that we should be keeping in mind while interpreting the results of HbA1c is that when can you get an abnormal HbA1c? What are the potential confounders, and what are the available alternatives? If at all we are getting a false value, we should be aware what alternatives do we have with us. So the high values of HbA1c can be seen in uremia, as in case of CKD, because in uremia, there is a chemical modification of hemoglobin into carbamylated hemoglobin, and that has similar isoelectric pH to HbA1c, and it will give you a falsely high illusion on cation exchange HPLC method. Similarly, your chronic high doses of aspirin causes acetylation. The same chemical modified, same acetylation of HB will interfere with giving you false high values of HbA1c. Lead and opiate toxicity have also been shown to give false high values, but the mechanism is as yet unknown. Yet another way is when there is a reduced turnover of the RBCs. Then what will happen? Because there is a reduced turnover, the exposure of the RBCs to glucose is much more, and therefore you will see a higher false value of HbA1c. When can you get false low values? You can get it if you are giving a therapy for management of hemolytic anemias, like vitamin B12 or iron therapy or erythropoietin. This will increase the number of young RBCs. It will increase the rate of erythropoiesis, and young RBCs will increase, which do not get enough time to get glycated. And therefore, you will get false low values. In addition to that, a reduced lifespan of RBCs, as in thalassemias or hemoglobinopathies or hemolytic anemias or splenomegaly, that can also give you false low values. And a significant accidental blood loss. In a road traffic accident, there's a sudden loss of blood, huge volumes, that will also give you false low values. There are certain assays like hypertriglyceridemia. They also interfere with the values of HbA1c. So this was a very interesting case that came to our lab. This was a 58-year-old homemaker from Hyderabad, and she was a CA right breast patient, was operated way back in 2000, December 2000, had swelling of the right limb, had the left side was fine. There was no palpable lymph node. No, the per abdomen examination was also fine, soft, tender, no organomegaly. But her fasting sugar was 129. PP sugar was 133, and HbA1c on D10 analyzer was 8%, which did not quite match with the blood sugar levels. So what we did was we checked her sample once again on BioRad variant, because we suspected there might be some falsely high values of HbA1c, and we saw an unusual P peak rather than the HbA1, and it was just close to the HbA1 area, and this high peak indicated that there is some variant. And when we went for DNA sequencing analysis of this patient, we found that there was this hemoglobin rally that was causing an unusually high P2 peak. Then we did an immunoturbidimetric analysis, and we found that HbA1c was actually just 4.8%. And so immunoturbidimetric assay was not affected by the hemoglobin rally. So what are the alternatives? If we have this problem of confounders with HbA1c in certain clinical scenarios, we should be thinking of an alternative test. So there is fructosamine and there's glycated albumin. Both these tests give you the glycemic monitoring over a duration of almost 2 weeks. Fructosamine measures all the serum proteins, and glycated albumin measures your total albumin. What are the guideline recommendations? So the recommendations for HbA1c, as we have been seeing that for diagnosis, it is more than 6.5. For pre-diabetes or high-risk diabetes, it's 5.7 to 6.4. The recommendation moderate is that the method used should be NGSP certified and ideally in an accredited laboratory. If it is a POCT screening, nowadays we do have POCT devices checking for HbA1c, then it should be done on a CLIA certified laboratory and an FDA approved device. HbA1c should also be measured routinely, usually every 3 months in a person who's diagnosed with diabetes. And once he achieves his glycemic goals, then every 6 months is also good enough. During pregnancy and in the preparation of women for pregnancy, for diabetes, they should achieve a glycemic goal which is much more stringent to avoid any risk of GDM, and should ideally be aiming for less than 6%. Further, the assays of other glycated proteins like fructosamine or glycated albumin, different clinical scenarios in different conditions, they can be used as I just told you. HbA1c should not be measured when you have a homozygous HbSS or HbEE, because it will tend to give you false values with HPLC methods. And laboratories they should be using HbA1c methods which are certified by NGSP and traceable to DCCT methods. Now, there are various, up till now, we've been talking about the diagnostic and screening tests, but there are lots of chronic complications that come along with diabetes. So there are lab tests which are done for assessing this risk. And diabetic nephropathy is one of the most common diabetic complication. And a large number of diabetics progress to the diabetic nephropathy and finally end-stage renal disease within 8 to 10 years of diagnosis of diabetes if it is very rapid. So the screening test is microalbuminuria. And we all know that the 24-hour urinary protein or albumin excretion is ideally should be less than 30 milligrams per 24 hours. And if you check the first morning void urine sample, the urinary albumin should be less than 20. And the ACR ratio should be less than 2.5 and less than 3.5 in male and female respectively. Any increase in the 24-hour albumin excretion between 30 to 300 is microalbuminuria. 20 to 200 for urinary albumin in the first morning urine void again indicates progression of the diabetic kidney disease. And frank albuminuria greater than 300 mg per dl or urinary albumin greater than 200 mg per liter, it is indicative of a progressed diabetic nephropathy. So what are the guidelines? The urinary albumin should be measured annually in the adults with diabetes. It can be done using the spot urine albumin to creatinine ratio, and it has a very high recommendation. So further research will not add to any value, but yes, it is the gold standard which should be done. If the eGFR, estimated GFR, is less than 60 ml per minute per 1.73 meter square, and or albuminuria greater than 30 milligrams per grams of creatinine in a spot urine sample, the urinary ACR should be repeated every 6 months. So it's just the first stage of your diabetic nephropathy progressing. So the moderate recommendation is there and we can be repeating it every 6 months. The first morning void urine sample can also be used with a moderate recommendation. Now, in 2019, ADA gave this statement that in patients of CKD of various stages, at least once a year, screening should be done for urinary albumin. Whether it is type 1 patient with a duration of greater than 1 year, or it is a type 2 diabetic patient, it should be measured and screened at least once a year. And as the progression is there, the frequency can increase and accordingly, the patients can be started with various interventions and if necessary, prepare for a renal replacement therapy. Now, ICMR guideline of 2018, they gave an algorithm for the screening for the diabetic nephropathy screening. And what they said is do a dipstick test of proteinuria. If it is negative, then do a dipstick test for microalbuminuria. If it's negative, then you can just come around and do the yearly screening of microalbuminuria. But if your dipstick test with microalbuminuria is positive, then you have to rule out uncontrolled diabetes, uncontrolled blood pressure, or urinary tract infection. Repeat the microalbuminuria again in the sample in 3 months. If it is positive, please refer the patient as a diabetic nephropathy progressive stage, and you can refer him to a nephrologist or a specialist diabetologist. If it is negative, then it comes for screening after 1 year. Now, if the dipstick of proteinuria is positive, then test the proteinuria sample at a timed sample. That is either morning early void sample or a 24-hour urine sample. And if it is high, then we have to check for the retinopathy in the diagnosed diabetic patient or if even in an undiagnosed diabetic patient. If it is absent, then you have to think of some non-diabetic proteinuria might be underlying. And then in that case, the nephrologist would be looking into the possible causes. And if it is retinopathy is present, then again, it indicates the presence of diabetic nephropathy. Another important complication which we see with diabetics is the cardiovascular disorders. And so lipid profile is the preferred test that is done, which includes your total cholesterol, triglycerides, LDL, and HDL. And according to the standards of medical care in 2019 by ADA, they said that obtain a lipid profile at the time of diagnosis of diabetes. at the initial medical evaluation, and thereafter every 5 years it can be done if the person is under the age of 40 years. And more frequently if it is indicated with the family history or with the lifestyle of the individual. Another way is just obtain the lipid profile while the investigation is while the hypolipidemic drugs or statins are started. And after that, after the therapy initiation, every 4 to 12 weeks, or any change in the dosage or annually, the lipid profile should be checked. Now, these were the major chronic complications that follow diabetes, but there are certain acute complications of diabetics as well. The first one that comes to mind is diabetic ketoacidosis. It is very commonly seen in type 1 diabetics, and sometimes it may be seen in uncontrolled type 2 diabetics as well. And it precipitates as vomiting, fruity odor, or increased pulse, stomach pain, dry mouth, flushed face, sleepiness. So we'll just quickly see a case where there was an elderly gentleman who reported to the emergency department with hematemesis, and he already had a poorly diagnosed type 2 diabetes. He was already on insulin replacement, was an alcoholic, and the patient was admitted due to a recent increased consumption of ethanol. So when ethanol is consumed, we assume that there might be alcohol-related changes in the blood profile. And what was seen was that the pH was 7.23, slightly acidotic. Glucose was raised, 200 mg per dl. Bicarbonates were depressed, lactate was high, anion gap was high. The beta hydroxybutyrates were high, and urinary ketones were 2+, plus alcohol 209 mg per dl. Now, this case is a classical case of ketoacidosis, but here there's a overlap of both alcoholic as well as diabetic ketoacidosis, and so the individual would be managed accordingly. Now, what are the guidelines? The guidelines for ketosis is that individuals who are prone to ketosis, like type 1 diabetics, or those who have a history of DKA, or even patients on SGLT2 inhibitors, they also have a side effect of having ketones in their urine. They should be screened. And if they are getting screened, then the recommendations are moderate for checking the blood beta hydroxybutyrate. It should be used for the diagnosis of diabetic ketoacidosis and can be used for monitoring. But the blood ketones based on nitroprusside are not recommended, should not be doing that. Another critical acute condition is hyperglycemia, hyperosmolar state. Now, this was a very interesting case. It happens very rarely. Although you might see children coming in with type 1 undiagnosed diabetics in state of hyperglycemia and hyperketosis. But this was a case that I found while searching the literature, that this was a 7-year-old girl with a 3-day history of polyuria, polydipsia, letharginess, and extreme weight loss over 7 days. And her labs showed that the glucose was undetectable by glucometer. And in laboratory, it came to almost 1167 milligrams per deciliter. pH was slightly acidotic, but her osmolarity was very high. So this was a typical case report of hyperosmolar hyperglycemic state in a 7-year-old child that was published in 2017. And this child's further lab investigations confirmed the diagnosis of type 1 diabetes, as her HbA1c was high, her C-peptide levels were low. She was tested positive for anti-GAD and anti-insulin antibodies. And her condition was corrected using insulin infusion and rehydration using isotonic saline. So this is something which should be kept in mind. And lastly, one of the most common acute condition that is seen in diabetic patients is hypoglycemia. Now, this hypoglycemia in diabetics can be caused because of an overdose of insulin or an overdosage of medication of hypoglycemic drug, exercise without the routine meals or delayed meals, or not taking the medication at all, or delaying and skipping the meals. All these can cause hypoglycemia, and there will be typical symptoms of shaking, trembling, faster heart rate, extreme hunger, dizziness, confusion, sweating. And this condition can be simply managed by given by giving either oral glucose, and if the person is unable to help himself or herself, then an IV dextrose may be given. What are the guidelines for some miscellaneous tests? Now, there's a lot of excitement while we think about the various immunoassays that can be done for a diabetic patient for monitoring or diagnosis. But the David Sachs working group clearly says that these assays are primarily for research purposes, and they should not be used for like routine diagnosis. Say, for example, you may use C-peptide just to confirm the differentiation of type 1 and type 2 diabetes, but it cannot be a standalone test. The good practice point would be if we could harmonize investigations like insulin and C-peptide across the various labs, because it still lacks harmonization. And there is a very low recommendation for estimating insulin antibodies in the routine care. So routine care does not require any kind of estimation of the insulin antibodies. So what is our take-home message? Yes, diabetes is a formidable foe with multiple acute and chronic complications attributed to it. Proper and timely lab investigations can have a great impact on monitoring of diabetes and its complications, thus improving the quality of life. And we laboratorians shall continue this war against diabetes by providing accurate diagnostic testing, conducting research, educating the stakeholders, monitoring the treatment efficacy, and contributing to the quality improvement efforts. So this World Diabetes Day on 14 November, we should pledge what I just said, that we should continue our fight against this menacing disease, diabetes. Thank you for your kind attention. If there are any questions.
No, ma'am, there is no question in the chat box.
Thank you so much. Thank you for this opportunity. Thanks a lot.
Good morning. Should I start?
Yes, sir.
Okay. So good morning, everybody. Can you hear me?
Yes, we can hear you, sir.
Okay. So my topic is kidney injury, but I deliberately changed it to acute kidney injury, because by kidney injury, generally we mean acute kidney injury. And the chronic kidney diseases are called CKD, or chronic kidney diseases, which are chronic in nature. And this is a separate entity. Mostly, sometimes acute kidney disease progresses on to develop chronic kidney disease. So we will try and stick to acute kidney injury in today's lecture. So what is acute kidney injury? If we see the definition, it's actually the sudden loss of excretory function, excretory kidney function. And generally, it's defined as a rise in serum creatinine levels more than 3.3 milligram per DL from the baseline within a period of 48 hours, or at least 50% higher than the baseline within a week. And sometimes this may be up to less than the urine output may be up to less than 0.5 milligram per kilogram body weight per hour for longer than 6 hours. So These are the commonly accepted definitions of acute kidney injury. And if you look into the staging of acute kidney injury, you will find that it's generally classified into 3 stages: stage 1, 2, and 3, based on the serum creatinine criteria and urine output criteria. And this is well established in the textbooks for quite a long period of time. So the stage 1 is minimal rise in, sorry, uh, okay, some the disturbances are coming in this. Just wait. Yeah. So okay. So the
Sir,
stage
can you
2.
please share it again?
Share the screen again.
Yeah.
Is it disconnected? Okay, just
Yes, sir. Someone is an.
okay. Just hold on. Yeah. Can you view it now?
Yes, sir.
Okay, great. So the stage 2 is increase in serum creatinine to more than 200 to 300%, whereas in stage 3 it is more than 300% from baseline. And accordingly, the urine output criteria gradually falls from 0.5 ml per kilogram per hour for more than 6 hours, then in stage 2 for more than 12 hours, and in stage 3 less than 0.3 ml per kilogram per hour for 24 hours, or anuria for 12 hours. So that is how we generally stage acute kidney injury. And if we look at the prevalence, acute kidney injury affects more than 13 million people worldwide each year, with almost 1.7 million deaths resulting from it. These 85% of this, the majority of these people are actually living in the developing countries. And you can see South Asia, which covers India, has a huge prevalence of acute kidney injury. And in India, if you look into the scenario, you will find that most of this 5 to 7% of acute care hospital admissions go into acute kidney injury. 30% of admissions in the intensive care unit goes into developing acute kidney injury, and the mortality rates may exceed 50%. In India, the causes are mainly in community acquired, yet 90% being potentially reversible. Whereas in developed nations, it's mostly hospital acquired, occurring in an ICU setting. If we look into the clinical patterns associated with AKI, we'll find a varied degree of heterogeneity, uh, where actually you will find presentations coming in from oliguria, anemia, vomiting. Sometimes even it may present with polyuria. So when we are talking about acute renal failure or acute kidney injury, the classification of the etiology may be seen as from pre-renal point of view, intrinsic renal damage, or some post-renal causes. And these pre-renal causes generally leads to absolute decrease in effective blood volume, or a relative decrease in blood volume, arterial occlusion or stenosis of renal artery, or some hemodynamic forms, which may be due to the use of AC inhibitors, NSAIDs. The intrinsic renal damage comes from mostly vascular causes, acute glomerular nephritis, acute interstitial nephritis, and sometimes acute tubular necrosis, which may be again due to some ischemic cause or nephrotoxic causes. Post-renal causes will coming from the obstruction of the collecting system or extrarenal drainage. However, the presentation of acute renal failure or acute kidney injury more or less remains the same, and the diagnostic criteria, the staging, remains almost same for all the 3 etiological factors. So the diagnostic modalities generally include serum creatinine, urine output. Urine analysis also gives us a good amount of information regarding the cause in terms of presence of blood cells, proteins, cast, which can indicate where the damage in the kidney is. Imaging studies help us ultrasounds, CT scans, MRIs to visualize the kidney and check for any structural abnormalities. Sometimes renal biopsies are also needed to analyze whether what the cause for kidney injury is. However, some additional tests also guide us during therapy, which generally includes a blood chemistry panel, electrolyte measurements, and assessment of fluid balance to evaluate the severity of AKI and associated complications. If you look into the spectrum of kidney injury, from the normal kidney, there starts a process where the risk of injury increases. Then this goes on to develop some damage, which leads to the decrease in GFR, and finally to kidney failure, leading to death. Serum creatinine, which we generally evaluate for assessing kidney function, is a consequence of a decreased GFR. So you can imagine that a lot of things have happened before serum creatinine is actually elevated in our body. And that represents a very important unmet need in terms of the biomarkers for kidney injury. So people have tried several risk assessment methods. So to predict the risk of AKI, some factors, like one paper which tells about risk factors as chronic risk factors, like presence of CKD and AKI developing on the background of CKD, maybe coexisting liver disease, heart disease, hypertension, atherosclerosis. These all are increasing the risk for development of AKI in an hospitalized patient, or whenever any etiological trigger happens. There may be acute risk prediction scores, which are generally associated with acidosis, some nephrotoxin exposure, some infections, mechanical ventilation, and anemia. A renal angina index has also been proposed, which takes into account the risk strata and also the injury strata, and then multiplies the risk into the injury, and the scores are then given in a scale of 1 to 40. This helps us to understand how much the risk of renal ischemia or acute kidney injury is there. Then there is also a classification which says that which takes into account the damage by assessing the kidney damage by assessing any biomarkers, and whether there is any so no functional change, that is creatinine levels are negative or not elevated, then there may be some changes, damage is present, but without the loss of function, which is called subclinical AKI. So creatinine levels have not yet increased. There may be some functional changes where creatinine positive, where the creatinine levels are actually increasing, functional change, but not much structural damage. So this is called pre-renal azotemia, and some damage with loss of function, which is the intrinsic AKI. So how do we find an ideal biomarker for kidney that should reflect correctly the kidney condition? It should be easy to collect, maybe non-invasive, it should be stored easily, better reproducibility should be attached to it, and that can be standardized across labs measuring it. And urinary proteins have been shown to remain stable long enough to enable performance of reliable proteomic analysis. So a lot of studies have gone into studying these urinary proteins as potential biomarkers. We'll come into that later on, but first of all, we'll go into the common traditional kidney function tests. So generally, the kidney function tests include the evaluation of serum and urine. And in serum, generally, we include parameters like urea, creatinine, uric acid, sodium, potassium, chloride, and sometimes some additional parameters like calcium or phosphate. And in urine, we look into parameters like albumin, protein, albumin creatinine ratio, and we also measure or estimate the GFR. So these things comprise a complete evaluation of the kidney function. So we examine the urine, we examine the serum for biochemical examination. The tests we can divide for glomerular filtration assessment, where we generally assess the filtration by clearance. Then we sometimes do tests for renal plasma flow, which are generally done through para-aminohydride test or filtration fractions. Some tests are best to assess tubular functions, and there are some radiological investigations pushing some dye into the venous blood and assessing for intravenous pyelogram, radioactive renogram, radioactive scanning. So these things can help us in assessing the kidney function. But the most commonly used method is evaluation of serum creatinine. And this serum creatinine is currently estimated mostly using automated analyzers on a colorimetric reaction known as the Jaffe reaction, or sometimes an enzymatic assay. This Jaffe reaction is subject to some interferences, negative interferences from bilirubin, and sometimes positive interferences by ketones and proteins. By the word interference, I mean to say that these presence of bilirubin in the serum sample may lead to a false elevated estimation of creatinine. The enzymatic methods, on the other hand, most commonly creatinine immunohydrolase or creatinine PAP method, these are having less interferences, but there are certain reports of interfering substances. If you look into the picture of how serum creatinine is getting correlated with GFR, we must understand that serum creatinine varies inversely with the GFR. So in mild kidney disease, so if you look at this graph, the x-axis shows the glomerular filtration rate. So a normal person will have a glomerular filtration rate of around 120, and gradually it decreases towards the left. And the serum creatinine is represented in the y-axis, which is increasing from 0 to 8. If we can observe, when a person is gradually having a decline in the GFR, the serum creatinine initially rises very slowly. So it actually becomes higher than the reference intervals only when almost more than 50% of the kidney GFR has already fallen. However, in advanced disease, marked rise in serum creatinine reflects a small absolute reduction in GFR. Smaller GFR decrease is accompanied with a marked rise in. So from 4 to 6, there may be hardly a GFR decrease from maybe 35 to 25%, 25 ml per minute. But it shows a marked rise. So this trend we have to just remember while we interpret this test. So what is GFR? GFR actually gives us a rough measure of the number of functioning nephrons. It is the glomeruli, the filtering units of the kidney, filter approximately 180 liters per day of plasma. And the normal value of GFR depends upon age, sex, and body size. To define GFR, it's always, we have to remember, it's the amount of plasma which is cleared of a particular substance per unit time. So GFR can be calculated using a lot of substances, both endogenous and exogenous. However, an ideal filtration marker is defined as a solute that it should appear endogenously in the plasma at a constant rate, should be freely filtered at the glomerulus, should neither be reabsorbed or secreted by the renal tubule, should not undergo extrarenal elimination, should be non-toxic, and should not be changed during its excretion process by the kidney. That is, it should not be metabolized within the kidney. So these factors will help help us to get a marker which is ideal for estimation of GFR. And it is measured in the form of clearance actually, where CZ, that is the concentration of that particular substance, is equal to urinary concentration into the flow rate of urine divided by the plasma concentration. So in AKI, GFR measurement has its own value. In patients with kidney disease, reduction in GFR implies either progression or underlying disease. GFR has prognostic implications in patients with CKD also, So on a background of CKD, if somebody already is developing AKI, then the measurement of GFR is very important. However, GFR cannot be measured directly and it is very time consuming and cumbersome to do in clinical practice. But GFR is very important because it needs to be taken into account before dose adjustment for medications, especially when a person is in renal failure, and sometimes prior to kidney donation if these patients need a renal transplant. So urinary clearance is actually an indirect measurement of GFR, which is generally used. So what is clearance? It is the gold standard for measurement of clearance is inulin. There are some other direct methods as well, like radioactive isotopes, iothalamate, iohexol, DTPA, but these are are measured using radiological techniques. So in the lab, generally we use some exogenous or endogenous markers. Endogenous markers, the most commonly used method is the creatinine method. However, cystatin C and urea can also be used to measure clearance. The gold standard is inulin. So creatinine clearance is the most common method that we use, and practically creatinine clearance tends to exceed the true GFR by approximately 10 to 20%, since this is the fraction of urinary creatine that is derived from tubular secretion. Creatinine clearance is usually determined from a 24-hour urine collection, since shorter collections tend to give less accurate results. Unadjusted creatine clearance values should be used for, by unadjusted, I mean that the creatine clearance is generally adjusted to the body surface area, but unadjusted creatine clearance values are also useful because it should be used for determination of drug doses. However, to compare the creatine clearance of any particular person with the reference ranges and to determine the severity of kidney disease, the adjusted value should be used. Our previous speaker, Dr. Purvi, had already told you how the unit of creatine clearance is. It's per 1.72 meters square body surface area, ml per minute per 1.72 meters square of body surface area. There are limitations of creatine clearance, although it is used in the most commonly for estimation of GFR. The three major errors are incomplete urine clearance. Then there are issues of analytical component where some labs might not have the clearance, the create method of creatinine estimation standardized to the reference method, that is isotope dilution mass spectrometry, IDMS, and increasing creatinine secretion in the post-analytical increases in creatinine secretion as GFR falls can limit the interpretation of creatinine. That means in normal subjects, approximately 15% of the urinary creatinine is coming from derived from the proximal tubule by secretion. However, in a setting of AKI, this value can rise to as high as 50% in patients with advanced kidney disease. So in that case, creatinine clearance will overestimate much more the existing GFR. Sorry, underestimate. Interpretation of creatinine clearance is also to be taken into account because creatinine is an organic cation in the physiologic range, is secreted by the organic cation secretory pump in the tubules, and this secretion can be inhibited by certain other organic cations like lactate. So in cases of lactic acidosis or any other types of metabolic acidosis, this the creatinine clearance may the tubular secretion of creatinine may get hampered. That may lead to more accumulation of creatinine in the body. Some drugs also interfere with creatinine evaluation, like antimicrobials and trimethoprim, H2 blockers like cimetidine, ranitidine, famotidine, and tyrosine kinase inhibitors, which are commonly used in a transplant setting like imatinib. These are commonly interfering with the creatinine measurement. Although creatinine is measured by the alkaline picrate method most commonly, colorimetric assay can recognize other compounds as creatinine comorgens, particularly the acetoacetate in diabetic ketoacidosis or bilirubin. So these two are very commonly associated with patients in AKI, sometimes who are having hepatorenal failure, and also sometimes who are leading to AKI in a setting of diabetes, pre-existing diabetic nephropathy. So this may affect the estimation of creatinine. There are drugs like fluoxetine and flucytosine and cefoxitin, which are producing also similar effects. Other analytical limitations include the differences in methods and equipments which are used for measurement of creatinine. So the National Kidney Disease Education Program had actually advised to standardize the creatinine assays so that they are traceable to reference materials based on IDMS. The variation in serum creatinine measurement methods leads to variation in creatinine-based GFR assessment, and that has led to standardization efforts across laboratories for this purpose. So another way of estimation of GFR is not by direct measurement, but by estimating it through some equations which use serum creatinine to calculate GFR. We call them estimated GFR or eGFR. The most useful equations are first there was the Cockcroft-Gault equation, then there was the modified renal modification of diet and renal disease study equation (MDRD), and currently the CKD EPI equation is being used. These equations improve upon serum creatinine by incorporating the demographic and clinical variables. These, if you look into the formulae, they will have these incorporated into them as certain factors. CKD API is thought to be more accurate than MDRD, but both are more accurate than Cockcroft-Gault equation. But they do not provide accurate estimates of GFR in settings where the GFR is changing rapidly. So sometimes in AKI setting, which is associated with a pre-renal ischemia and which is being corrected, then the usefulness of these formula might not be holding true. This is the Cockcroft-Gault formula. I will not go into the details of it. However, the Cockcroft-Gault formula almost overestimates creatinine clearance by 10 to 40%. And the equation was developed prior to the standardization of creatinine assays and has not been revised yet. So generally nowadays it's avoided. Most commonly the MDRD and the CKD EPI equations are followed nowadays. But the MDRD formula has to be used with creatinine values coming from methods which are standardized by the isotope dilution mass spectrometry. The CKD EPI equation is considered superior when GFR is normal or mildly reduced, and CKD EPI equation performs better at higher levels of GFR. Whereas in contrast, the MDRD study equation performs better at lower levels of GFR, that is in advanced stages of CKD, or even in cases of AKI, these will perform well. Cystatin C is a new marker. It's not that new. It's been in use for a long time now. It's a low molecular weight protein, but it's freely filtered by the glomerular, but not reabsorbed, but it is catabolized in proximal tubules. That prevents it becoming an ideal endogenous marker, but it's useful in indicating early changes in kidney function. However, it's quite expensive, and it is measured only by chemiluminescence assays or nephelometry, very sensitive assays. Substantial variation in assay has been observed, and that's why it's not been useful in that proportion that it was thought to be. Comparing the equations of GFR based on cystatin C, no difference in the bias was observed. Precision, however, was observed to be worse than the creatinine-based assays. However, the advantage of cystatin C over creatinine is that it is not affected by age, muscle bulk, or diet, and it is more reliable marker of GFR than creatinine, particularly in early renal impairment. Cystatin C concentrations may be affected by presence of cancer, thyroid disease, and smoking. So that's where we'll have to be a bit careful when we are using this for patients with background disease of cancer, thyroid disease, or smoking. So why I told that it is a marker useful for in early stages of CKD or AKI is that it is rising much earlier than creatinine. This plot, the dotted lines are the cystatin C, and the non-dotted lines, the bold lines, are for the creatinine. And if you see the whenever the GFR is falling at early stages where the GFR is between 100 and 60, clearly cystatin C is rising beyond its cutoffs, and so early detection of nephropathy or any kidney damage can be easily captured by this cystatin C. Whereas in the late stages, creatinine values rise much vertically. So again, we come back to the staging of acute kidney disease. This is, I'm trying to summarize what I've told, that it's based on serum creatinine and urine output. However, newer markers have also come up. So there are functional biomarkers. We have discussed this, creatinine and cystatin C. There are tubular enzymes, which are some of these enzymes are sometimes useful, but not much in use. There are certain markers which help us to understand where the kidney damage. Most important among them is KIM1 and NGAL. Cystatin C also reflects some amount of kidney damage, and it is also complemented with albumin estimation. There are some pre-injury phase biomarkers, which is the major area of research currently to identify these biomarkers before the kidney damage onset sets in. So what is KIM1? KIM1 is basically a transmembrane glycoprotein, not usually detected in normal kidneys, and the basal expression is low in normal kidney. However, it is upregulated after ischemia reperfusion injury. Thus, it's a marker of proximal tubular epithelial cell injury and reconstruction. Only thing is, it is detected after around 12 to 24 hours after the AKI has been set in. It's still much before the other markers like cystatin C or creatinine. Its strength as a biomarker stems from the fact that it has proved to be more specific for certain etiologies of AKI like acute tubular necrosis. So when we are talking about differentiating between a pre-renal acute kidney injury and an acute tubular necrosis, KIM1 is the marker of choice. The second marker is neutrophil gelatinase associated lipocalin, NGAL, as it is commonly known. These are small proteins. NGAL binds to the surface receptor and megalin. So after ischemic or nephrotoxic kidney injury, intrarenal NGAL is dramatically upregulated. This NGAL, elevated NGAL, is detectable in the urine as early as 3 hours after injury. So this is it is earlier than KIM1, but it's not very specific for the kidney. NGAL is a biologic response to the release of liable iron from injured tissues in the setting of ischemia, sepsis, and toxic insults. And it is synthesized and secreted by tubular epithelial cells of the proximal and distal segment and freely filtered by the glomerulus. Serum NGAL was found inferior to urinary NGAL as a biomarker for acute kidney injury. One caveat is that NGAL is that constitutive expression in its constitutive expression in chronic kidney disease states markedly increases the baseline level. So if a patient is having already existing CKD or any ongoing kidney damage, then it's not very useful to measure the absolute values of NGAL to detect AKI. However, a relative rise may be helpful in this setting. So, how does NGAL actually comes into the urine? It's coming from the neutrophils, but it's going through the extracellular nanovesicles and exosomes, and finally it's released in the urine. We'll not go into the details of it. The next marker that we'll talk about is IL-18, interleukin 18. It's synthesized by many tissues, including the proximal tubular epithelial cells. And ischemic injury and inflammatory states trigger these intracellular cleavage of this immature IL-18 to the active form, which is then detected as a marker of urine marker in the urine as for kidney injury. So higher levels of IL-18 appear to correlate with ischemic AKI and compared with other etiologies for AKI. So for ischemic AKI, IL-18 is having some degree of specificity. It also offers some prognostic information and reflects the severity of illness and mortality at the time of AKI diagnosis. But like NGAL, IL-18 has also not met the criteria to be used as a marker for AKI based on studies performed till date. So currently, only KIM-1 is a molecule which is recommended to be used for kidney injury, acute kidney injury. Another protein is beta-2 microglobulin. This is a small non-glycosylated protein found on the surface of most nucleated cells. Elevated serum levels indicate increased cellular turnover as in myeloproliferative or lymphoproliferative disorders, inflammation, and renal failure. So it's quite non-specific. And a measurement of B2M or beta-2 microglobulin is clinically used to assess renal tubular function in renal transplant patient. So this is the most important thing to remember, that for transplant patient, to assess whether there is an organ rejection or not, beta-2 microglobulin is a very good marker. So the new injury markers, new biomarkers for detecting AKI post-injury is we are having an evaluation table. We can see that cystatin C I've talked about, IL-18 I've talked about, KIM-1 and NGAL. So you can see that these markers have uses for different types of injuries. So cardiopulmonary bypass, most often this will result in a pre-renal ischemic injury, whereas contrast nephropathy will lead to an damage of the tubules, acute tubular nephrosis, acute tubular necrosis. Then there may be sepsis or ICU, which again may be due to septic shock leading to a pre-renal injury, and in cases of transplant patients. So in these different settings, these markers can be detected prior to the rise of the creatinine and other renal failure markers. Then there are certain newer markers which are again coming in. I will not go into the details of it, just naming them so that we are acquainted with the names. Urinary liver fatty acid binding protein, LFABP. It's a possible early biomarker, not yet validated. Then there are substances like tissue metalloproteinase 2, TIMP2, insulin-like growth factor binding protein 7, IGFBP7. Urinary calprotectin has recently come up as a possible biomarker. Then chitinase 3-like protein 1 and DICOF 3. These may be developed as biomarkers later in. The next important aspect is proteinuria. So proteinuria is one thing which is another criteria by which the kidney damage is assessed, apart from GFR. So glomerular proteinuria and tubular proteinuria, two different types of proteinuria are generally happening. And these are glomerular proteinuria are caused by defects in perm selectivity of the GFR, glomerular filtration barrier, to plasma proteins. And for example, in cases of glomerulonephritis or nephrotic syndrome. And in nephrotic syndrome, urine protein excretion exceeds more than 3.5 gram per day. It's associated with edema, hypovoluemia, hypercholesterolemia. Whereas in tubular proteinuria, it's caused by incomplete tubular reabsorption of protein. So when we talked about beta-2 microglobulin, we said that these proteins are generally freely permeable in the liver, in the glomerulus, but it's also getting reabsorbed by the tubules. If there is a problem in the tubular reabsorption, these proteins will be coming in the urine, resulting in higher proteinuria. There is something called overflow proteinuria also, which is caused by increased plasma concentration of proteins. For example, multiple myeloma, where Baines-Jones proteins are found. There are cases of myoglobinuria, which is accompanying cases where there is traumatic muscle injury. Then urinary tract inflammation or tumor also may lead to proteinuria. Albuminuria versus proteinuria is an important thing to understand. Albuminuria refers to the abnormal presence of albumin in the urine. Microalbumin is nowadays generally considered an obsolete term because there is no such biomolecule. We generally nowadays refer to as urine albumin. It was previously known as microalbumin because these were not getting detected by the technology or the equipment that were available at that time. But nowadays, the range of detection has gone down, the sensitivities have increased. So nowadays we call it albuminuria. Normal urine protein is up to 150 milligrams per day, which comprise of roughly 30% of albumin, 30% of globulin, and 40% of TAM horse proteins, which come from the tubule. For estimation of albuminuria, generally we have two types of samples, 24-hour samples versus spot samples. Urine albumin may be measured in 24-hour urine collections or early morning or random samples. Whenever we are doing in a spot sample, it's advisable that we measure it as albumin creatine ratio, and the KDIGO guidelines advocate the usage of albumin creatine ratio in spot urines for classification of people. Before we end, we also will discuss a bit about this fractional excretion of sodium. This is a useful test sometimes being done to distinguish between acute tubular necrosis from prerenal uremia, and this can be measured by measuring urinary sodium and creatinine and plasma sodium and creatinine. However, in patients receiving diuretic therapy, the FENA is not a reliable marker. Spot urine sodium, some concentrations of less than 20 millimole of sodium are sometimes an indicator of prerenal AKI. So this is a entity which was used very commonly previously. Nowadays also it's getting used. Before we conclude, we'd like to take your attention towards the newer evolving strategies toward identification of diagnostic biomarkers of acute kidney injury. So recently, people have reported miRNAs, which have been selectively found to be diagnostic biomarkers of AKI in ICU patients. Outstandingly, serum microRNAs estimated before cardiac surgery predicted AKI development later on. So several of them have been reported. Moreover, after surgery, the expression of mRNA was modulated days before serum creatinine increase, demonstrating an early diagnostic value. So probably this is where we are moving towards. And there are several papers. One of the papers again have reported three of them: microRNA 188, 30A and 30E as early biomarkers for contrast-induced acute kidney injury. So for acute tubular necrosis. There are certain future trends as well. We know the pathology of kidney injury, the glomerular injury. So there may be thickening of basement membrane, and the podocytes will be lost, where there may be some degree of fibrosis as well. So there are chances that these markers, TGF beta, VEGF, metalloproteinase, caspase, these can potentially become markers of glomerular injury, whereas mesangial cell hypertrophy and proliferation may be coming due to inflammation, where reactive oxygen species, IL-6 inflammatory markers may play a role and may be potentially developed as markers for kidney injury. However, these will always be non-specific because these markers are not specific for the tissue of kidney. So to summarize, we use measurement of GFR, and to do that, we do the clearance test. Nowadays, we do the eGFR. Endogenous substance is used for clearance, mostly the creatinine, and physical examination of the urine along with microscopic examination and detection of albumin is also used very much to classify GFR and predict AKI. Thank you for your patient hearing. If you have any questions, I'd like to answer. It seems there are no questions. So thank you again.
So we can move on the next lecture. Monica ma'am, you can start your screen sharing. Ma'am, you can start.
Yeah, just starting in 2 minutes.
Good morning, friends. Today we are going to talk about a very important investigations which is sent by us in day-to-day practice. That is interpretation of liver function test, which is a very commonly ordered investigation in all clinical scenario. ये move नहीं कर रहा. Liver function test, as we all know, the basis for this basis of this presentation is to know what are the basic tests which we order in liver function test, how the individual with abnormal LFT, how do we interpret that, and to recognize what are the common clinical conditions in which different parameters of LFT are deranged. So liver function and liver chemistries, they are not synonymous, because liver performs almost, you can say, 500 functions, more than 500 functions in our body. And but just by looking at few clinical biochemical parameter, we cannot say the exact situation how the liver is functioning. But grossly, we come to know about few of them. So liver function is not synonymous with liver chemistry. What we are interpreting, that is mainly the liver chemistry. Look at the functions of liver. There are metabolic functions, which involves carbohydrate metabolism. We all know that glycolysis glycogen synthesis, gluconeogenesis, HMP shunt, they all occur in liver. Coming to lipid metabolism, fatty acid synthesis, ketogenesis, cholesterol, a very important component in our body, the bile acid synthesis, even the hydroxylation of vitamin D to an active form, lipoprotein synthesis, all these occurs through liver. Protein metabolism, the synthesis of urea from ammonia, plasma protein, synthesis of coagulation factor, they all are through liver. The different hormone metabolism, their excretion of stress hormone, peptide hormone, that is all via liver. Coming to synthetic function, all the plasma, most of the plasma proteins, they are synthesized in liver. The clotting mechanism of our body is through liver, cholesterol, triacyl glycerol, and lipoproteins. They are manufactured in liver. Lot of excretory function in our body to excrete different types of toxins like bile acids, bile pigments, bile salt, they all are excreted through liver. The detoxification mechanism like conversion of ammonia to urea, certain drugs or xenobiotics, they are excreted through liver. We all think that pancreas is the regulatory body for diabetes, but now we know that liver plays a very important role in glucose metabolism by glycogenolysis and gluconeogenesis. Storage function, we know that glycogen, different vitamins A, D, E, K, B12, and iron, they all are stored in liver. So it is very important to assess that what are the different functions which we assess, how do they help us? They help us to know the liver functioning, about the liver damage. The biliary system functioning can be assessed by LFTs. Many of the therapies we monitor by looking at LFTs, some drug monitoring, some clinical conditions monitoring. Extrahepatic, some of the dysfunctions like coagulation status of the patient, hemolytic part of hemolysis, that can be assessed by LFTs. A very important parameter is the nutritional status. About just by looking at the LFTs, we can tell about the nutritional status of the person and the body bone mass and bone turnover. So look, the information from LFT is not only about the liver, it is about biliary system, it's about the hemolytic system, bone and nutrition. So the lot of information we can get by looking at the blood test through LFTs. Coming to what are the functions assessed by LFTs, first is a hepatocellular function. You can say we have aminotransferases, which includes AST, that is aspirate aminotransferases, or ALT is alanine aminotransferases. Second comes the alkaline phosphatase, commonly known as ALP. Then comes the GGT, that is gamma glutamide transpeptidase. And another test is 5-nucleotidase. This is mainly used in research labs, not commonly available in normal LFT profile. The second is a synthetic function of liver, which can be assessed by looking at albumin and international normalization ratio, that is the INR. Then bilirubin metabolism can be assessed by looking at bilirubin, which is total, direct, and indirect. So these are the tests which we order when we order a LFT. Coming first to transaminases, that means AST and ALT. Their normal values varies in males and females. You can see the slightly the values are lower in females as compared to males. What are the functions that transaminases perform? They catalyze reaction between keto acids and amino acids, and ALT is more specific for liver disease. AST can rise in liver disease, and besides liver, there are many other organs like skeletal muscle, heart muscle, kidney, brain, and RBCs related disorders in which AST can rise. Age, BMI, metabolic factors, they all can affect ALT levels. And transaminases, I have already mentioned, they are used in specifically management of hepatitis B and drug-induced liver injury. Like if a patient is already on ATT, the monitoring the side effects of ATT is by looking at the transaminases. And in case of hepatitis B management, when we start antivirals, we look at the transaminases level to think of starting or monitoring the therapy. The transaminases, there are number of causes of transaminases increases. One is a hepatocellular injury. This can be because of alcohol, viral, drug toxicity, autoimmune vascular injury, fatty liver, congestive hepatitis. So a lot of gamut of causes are there to cause hepatocellular injury. And you see AST and ALT, they both rise in these cases. Second comes the biliary injury. This could be bile duct, that means bile duct problem, maybe due to stone or cholecystitis, cholangitis, or cholangiocarcinoma. Again, the level of AST and ALT, they both rise. There are certain extrahepatic conditions like rhabdomyolysis, that is a muscle disease, acute myocardial infarction, and hemolysis. These are the causes in which we have AST rise, but ALT is normal. A word about transaminases, that ALT is more than AST in most of the chronic hepatitis stage. But once cirrhosis develops, this ratio reverses. Then the AST become more than ALT. Second important part in this is AST to ALT ratio. If this is more than 2, that shows that probably this injury is due to alcohol. And if this ratio exceeds more than 3, definitely this is going to be alcohol related. If this ratio AST, ALT is more than 5, that means there is disproportionate increase in AST level, that we should suspect extrahepatic sources of AST. That is, I have already mentioned in the previous slide, rhabdomyolysis, acute myocardial infarction, or other causes. Not only the ratio, when we see the range in which we get the report of transaminases, that in fact can lead to some suspicion in our mind that probably look for those causes. Like suppose the patient is coming with transaminases more than thousands, then what are the causes we should suspect? We suspect generally viral causes, viral hepatitis, ischemic hepatitis, drug toxicity, and paracetamol poisoning. This includes other drugs also. So whenever this is in thousands, we suspect viral, ischemic, or drug-induced injury. When the ALT, AST in alcoholic hepatitis or HELP syndrome, generally this is in the range of 300 to 400. And in cases of chronic hepatitis or steatohepatitis, generally the range of ALT, AST is in 200, or you can say it can reach till 300. Generally, this is the level of ALT, AST. So not only the ratio of ALT, AST, or the range in which we get the transaminases, we can suspect different causes accordingly. Then comes the second marker, that is alkaline phosphatase. What is alkaline phosphatase? This is a collection of isoenzymes which are present in our body. What are they? They form the family of zinc metalloproteinases, which catalyzes the hydrolysis of phosphate esters. And ALP we find in liver canaliculi, bone, WBCs, small intestine, placenta, and kidney. So look at the origin of alkaline phosphatase. We have so many areas, and how we can differentiate the origin of this? This is possible by isoenzyme fractionation, but which is not presently available in routine labs. Only in research purposes we can do this investigation. And ALP depends on age and gender. To help the interpretation of alkaline phosphatase, we have gamma GT. This basically transfers, this also catalyzes some of the chemical reactions in our body. It is, the origin is almost similar to alkaline phosphatase. This GGT has increases the hepatobiliary, basically increases mainly in hepatobiliary diseases. And the sensitivity and specificity is much more than alkaline phosphatase. GGT is not present in goat. So if we have raised alkaline phosphatase and if we have confusion that what is the source of alkaline phosphatase in the body, rise in alkaline phosphatase, then we can take help of gamma GT. If gamma GT is also raised, then probably the source of raised alkaline phosphatase is hepatic or hepatobiliary in origin. So you just look at this table. The alkaline phosphatase increases in biliary pathology, liver problem, high bone turnover or bone loss, bony metastasis, hyperthyroidism, parathyroidic defect, Paget's disease, and even in normal pregnant patients, some increase in alkaline phosphatase is seen because of this is synthesized by placenta. And the gamma GT, what are the conditions in which it is increased? Mainly in biliary pathology and hepatocellular diseases. Some increase can be seen in diabetes patients who are on drugs like phenytoin, barbiturate. Mildly increase can be seen in renal failure, pancreatic disorder, MI, and alcohol. These are the conditions in which alkaline mild increase in gamma GT is seen. So if a patient is having increase in gamma GT, probably we think of that this is biliary in origin or hepatocellular in origin. So this table shows that if a patient is coming, it has raised alkaline phosphatase, raised gamma GT, probably the problem is with hepatobiliary system. If alkaline phosphatase is raised too much, the gamma GT is also raised. Look for biliary diseases, because generally in hepatic injury, the too much of alkaline phosphatase is not raised. So if ALP is raised to a bigger level and gamma GT is also raised, look for the biliary disease. If ALP is elevated and gamma GT is normal, look for bone disease. And if ALP is normal and gamma GT is only gamma GT is increased, then probably the cause of the problem is alcohol induced. So just by looking at the NFT, if a patient is having only raised gamma GT, think that probably the patient is consuming alcohol. We have interpreted raised alkaline phosphatase, but sometimes we get a report of low alkaline phosphatase also. And many a time this is interpreted as this is a lab error, but this is not so. If we get a low alkaline phosphatase level, look for hypothyroidism, pernicious anemia, some zinc deficiency, and specifically in case when a patient is having chronic liver disease and with low alkaline phosphatase, look for the Wilson's disease, because that could be one of the cause for low level of alkaline phosphatase in the presence of liver disease. Coming next to the synthetic function of liver, that is the albumin. The normal value of albumin is 3.5 to 5.5 grams per deciliter. This is produced only by liver and it has got a half-life of 3 weeks. So it forms almost, you can say, half of the total proteins in our body, and it is negatively charged, binds to calcium, sodium, potassium, some hormones, conjugated bilirubin, and some of the drugs. It is the main force which maintains the capillary oncotic pressure, and the level, if decreased, this serum level of albumin is decreased, that means definitely the duration of illness is more than 3 weeks, because we know that the half-life of albumin is 3 weeks, and any chronic illness can decrease the serum albumin level. Then we have another parameter which we can assess by just by looking at the LFT, that is known as protein gap or gamma gap. This is defined as total serum protein minus serum albumin. So this normal value should be less than 4. If this value exceeds, what are the conditions which we suspect? Either we suspect sepsis, look for HIV, look for hepatitis C, and multiple myeloma can have increase in gamma gap. Autoimmune diseases, in this also the normal value of gamma gap increases. So looking at this, suspect number of conditions which we can confirm with further testing. Albumin in our body can decrease because of either there is decreased synthesis, which could be because of chronic liver disease, or the patient is malnourished, or they can be increased loss, which could be because of nephrotic syndrome or protein losing enteropathy, a rare condition in which the albumin loss is there through the enterocyte, or they can be internal redistribution, like if there is increased capillary permeability and the seepage of albumin from the capillaries to the extracellular space is there. AG reversal. This is again a very important parameter which, just by looking at the AG reversal, we can suspect that the early chronic liver disease is likely to be there, because this is a ratio which has got very high sensitivity and specificity. Coming to second synthetic function of liver, that is the INR. This is basically international normalization ratio. This is based on prothrombin time, which is dependent on the extrinsic clotting pathways in our body. This appears to be far more sensitive than albumin, especially when the injury is acute, because in acute injury, albumin may remain normal, but by looking at INR ratio, we can suspect that probably this is an acute injury to the liver. PT may be increased in severe liver disease. PT measurement may vary significantly between different labs. So to correct this, INR is a calculation which corrects the interlab variation of prothrombin time. So what we order PT INR. This is because the reading of INR is by a calculator corrects the interlab variation, which can vary from different methods used in different labs. What are the conditions in which INR is increased? This suggests there is decreased synthesis of clotting factors. So this can occur in chronic liver disease, acute liver failure, vitamin K deficiency, because all these clotting factors 2, 7, 9, 10, they are vitamin K dependent. So any condition in which vitamin K is reduced, like in malnutrition, fat malabsorption, use of broad spectrum antibiotics like which kills the gut microbiota, which were responsible for production of vitamin K. Patients who are on anticoagulant therapy like warfarin, comudin, dicumarol, they all increase they cause vitamin K deficiency in leading to increase in INR. Increased consumption, as we know that DIC is a condition in which the clotting factors are consumed. So this can lead to increase in INR, and even in hypothermia, a condition in which the body temperature decreases, so that can falsely give a high INR reading. Next comes the bilirubin physiology. We all know that how the RBCs are hemolyzed. Once the hemolysis of RBCs occurs, the hemoglobin is converted into, broken down into heme. Heme, through macrophages, is converted into biliverdin. Biliverdin is converted into unconjugated bilirubin, that is in the indirect bilirubin. Through glucurononic acid, this the conjugation of unconjugated bilirubin through glucuronic acid leads to conjugated bilirubin. So this bilirubin is excreted through biliary system. When it comes to urine, it forms urobilinogen. But when it comes to stool, it causes stercobilinogen. What happens? This conjugated bilirubin, a fraction of this bilirubin gets attached to albumin, which has got a half-life of 3 weeks. This is known as delta bilirubin. This is a concept which is very important sometimes clinically. Why? Because delta bilirubin is a fraction which causes delay in resolution of jaundice. Even if the patient is recovering from hepatitis or biliary obstruction is removed. The patients, they come, that suppose a patient is having biliary stricture, we have put a biliary stent and the bilirubin is not coming down, then that can cause panic, that why either the stent is not functioning or why it is not coming down. Then we can explain that this is delta bilirubin is the fraction which can still give the reading of raised bilirubin even if the obstruction has been removed. Bilirubin increased shows that either there is hepatocellular injury or biliary system pathology. So unconjugated serum bilirubin, we have seen where all we can have increase in unconjugated fraction. One is a hemolysis because there is more of RBCs are broken. So that causes more of unconjugated serum bil, which is high. To assess hemolysis, we can get other markers like decreased hepatoglobin, increased retic count, increased LDH. So by looking at these co-parameters, we can say probably some sort of hemolysis is going on in the patient. Some genetic disorders, they can cause increase in serum bilirubin like Gilbert syndrome or Crigler-Najjar syndrome, in which indirect bilirubin remains high. Another important condition is known as Gilbert syndrome, a very common clinical condition we see in our day-to-day practice, which is seen in almost, you can say, 5% of population. What happens here? There is mild increase in indirect bilirubin, and the patient is generally asymptomatic, and this bilirubin never goes beyond 6. And this is precipitated by fasting or any physiological stress on the body, like surgery or fever or any other stress. So what happens? The patient, they come with raised jaundice and they tell that this is a problem for last 5 years or 10 years that my bilirubin is not coming down. And when you see the reports, only the indirect fraction of serum bilirubin is high every time, with normal transaminases, normal alkaline phosphatase, normal ultrasound and other tests. So to convince them, we can get a test to confirm this. We can get an enzyme assay to confirm that this is Gilbert syndrome and that there is deficiency of that enzyme which can confirm the Gilbert syndrome. Then comes the conjugated serum bil. It is increase in biliary pathology, hepatocellular injury, and some genetic disorders like Dubin-Johnson syndrome, Rotor syndrome. So this bilirubin, if this is high in newborn, that is a problem, major problem, because this is very harmful for the newborn, especially when the bilirubin level goes beyond 20. This can cause neurological dysfunction. This is directly toxic to the neurons of basal ganglion and brain stem. It can cause increased sleepiness in the child, newborn, hypotonia, seizures, and death. And the patients who survive this episode, they develop kernicterus. This is a syndrome of permanent neurological sequelae in the survival. So a raised bilirubin in newborn is very, very important because the level of bilirubin that guides the further therapy, phototherapy, or other exchange transfusion, which is the decision taken by neonatologists after the level of bilirubin what they see. So these we have seen the individual parameters. Now we will concentrate on what are the patterns in which, when we combine these parameters, what are the patterns in which we interpret the results. First is a hepatocellular injury, means the liver hepatocytes are damaged. In those cases, there will be disproportionate increase in transaminases as compared to alkaline phosphatase. Second is a cholestatic pattern, in which there will be disproportionate increase in alkaline phosphatase as compared to transaminases. Mixed pattern in which both AST, ALT and alkaline phosphatase, they are raised. Then comes the infiltrative pattern. Whenever there is infiltration inside the liver, that will increase the alkaline phosphatase and gamma GT, may increase some bilirubin, may increase some transaminases, but predominantly ALP and gamma GT will be high. Isolated hyperbilirubinemia, that means there is only increase in serum bilirubin with normal AST, ALT and alkaline phosphatase. These are the 5 patterns which we can get when we order our LFT. So how do we interpret these patterns? We have a word called R ratio. What is R ratio? R ratio is basically ALT or ALT measured or ALT upper limit of normal divided by ALP measured or ALP upper limit of normal. This ratio, if we calculate, if this ratio is more than 5, that shows definitely this is hepatobiliary injury. If this ratio is 2 to 5, that shows a mixed pattern. And if this ratio is less than 2, it is a cholestatic injury. This is just a measurement. By looking at this ratio, we can calculate and we can think of what will be the probable site of injury. This is a table which again shows that if a patient is having hepatocellular injury, ALT, AST will be high, alkaline phosphatase may be normal or raised, bilirubin may be normal or raised, albumin may be normal or raised, or INR may be normal or raised. Then coming to cholestatic injury, in this AST, ALT may be normal or raised, ALP or GGT will be markedly raised, bilirubin may be raised or markedly raised, albumin may be normal till the time the injury is so severe that albumin decreases. INR again may be normal unless the problem is chronic and the injury is severe. Isolated hyperbil, in which only bilirubin is raised, rest of the parameters are normal. Isolated synthetic dysfunction is the condition in which only albumin is low, PT, INR is more, rest of the parameters are normal. In case when the patient develops cirrhosis, ALT may be normal, AST may be normal, alkaline phosphatase may be normal, bilirubin may be normal, or once the patient decompensates, the bilirubin may be high. The only parameters looking at albumin, reversal of AG ratio, and raised INR. These are the parameters which we look to say that the patient has developed cirrhosis. This is very important to understand that in case of cirrhosis, there is almost, you can see the normalization of all these parameters, AST, ALT, alkaline phosphatase, and mildly raised bilirubin. Even the bilirubin may be normal in compensated cirrhotics. So we must, suppose an alcoholic comes and says that these enzymes are normal, I don't have any problem. Just you look at the albumin. If that is reduced and INR is raised, or there is AG reversal, then you can tell him that probably he is having liver disease and he should further get investigated. Coming to individually hepatocellular injury, which I have explained, AST, ALT will be high, alkaline phosphatase may be normal or high, BIL may be normal or high, albumin may be normal or reduced, INR may be normal or reduced depending on the duration of illness. In this case, if we have AST, ALT ratio more than 2, that means probably the injury is due to alcohol. And if AST, ALT ratio is more than 5, that means probably the extrahepatic sources like rhabdomyolysis, that is the cause. And looking at the AST, ALT ratio more than 1000, always suspect either this is viral, either this is viral or drug induced or ischemic or some bud carry injury. So there are not many differential diagnoses. Looking at thousands of ALT, AST, suspect these causes. Coming to cholestatic injury, AST, ALT is increased, alkaline phosphatase is disproportionately increased, bilirubin may be normal or increased. Normally, albumin and INR are normal until the disease is very chronic and severe. So if ALP and gamma GT both are increased, look for biliary pathology like choledocholiasis, cholangitis, pancreatic mass or cholangiocarcinoma, or intrahepatic problem like PBC or primary sclerosing cholangitis. So they should be suspected. And to confirm this, we can get an ultrasound, CT, MRCP, or endoscopic ultrasound to clear the problem. Increased alkaline phosphatase with normal GGT, that means extrahepatic problem like bone disease is there. So we need to look for bone scan or malignancy workup, TSH, calcium phosphate. So all these accessory workup is required just by looking increased ALP and normal gamma GT, because in liver problem, both of them should be high. Unconjugated hyperbilirubinemia may be because of hemolysis, confirmed by increased LDH, decreased hepatoglobulin, positive Coombs test. Gilbert syndrome, I have mentioned, Kriegler-Naza, they all can cause only conjugated hyperbil, unconjugated hyperbil, and conjugated hyperbilirubinemia, we can suspect hepatobiliary disease. To confirm that, we get an ultrasound done. We can have Rotor syndrome or Dubin-Johnson syndrome because of they generally can be diagnosed on the basis of liver biopsy, in which we see the pigment deposition on liver biopsy. Then end stage of any chronic hepatocellular or cholestatic injury, if a patient is coming with cirrhosis, so that is the final end result of any type of injury. In this, we can have normal or raised ALT, AST, alkaline phosphatase may be raised, bilirubin may be in compensated state. This may be normal to it can increase in decompensated state. But I have already mentioned albumin and INR. These are the two parameters and the AG ratio, which can confirm that the patient is going into chronic stage. So end result of any chronic hepatocellular or cholestatic disease is cirrhosis. We must review the medication history of alcohol, viral pathology, autoimmune diseases, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency. We can get a CT done to rule out associated HCC, which can be confirmed by alpha-fetoprotein or PIVKA level. So these are the further investigation beside history. We can get a viral marker done, autoimmune marker done, workup for Wilson's, hemochromatosis. They all are the part of extended LFT. That is to know the etiology. Thank you. If there's any question, we can discuss it out. I can see Dr. Rekha Kumari. She's asking, in some cases only AST is high 3 to 4 times and ALT is normal. Yes, this can happen because AST can be raised in extrahepatic causes also, like in cardiac problem, muscle problem. So in those cases, this AST may be high and ALT may be normal. Sometimes only ALP is high and normal to other normal. Definitely, ALP is a marker of basically biliary pathology. So only if ALP is high and gamma GT is high, that shows that there is some problem in liver. But if only ALP is high and gamma GT is normal, then we suspect some other source of alkaline phosphatase. This could be placental in origin, this could be bony origin, or some extrahepatic. So by looking only at alkaline phosphatase, we cannot say it's purely hepatic in origin, because to say that this is hepatic, we need to have raised gamma GT along with alkaline phosphatase. I don't see any other question in the chat. Do we have any other question?
No, ma'am.
So I think I finished in time.
Yeah, ma'am.
So thank you. Thank you very much.
Okay. Now we are having a break of 25 minutes. We will reassemble at 11:30.
Okay. ठीक हो गया करते? Sure.
Institute of Liver and Digestive Diseases, Sri Balaji Action Medical Institute, Paschim Yard, New Delhi. So I will be talking today about a disease which is very, very common nowadays. In today's time, it is one of the most commonest diseases. It has taken over all other etiologies of chronic liver disease and is now the commonest cause for chronic liver disease as well as cirrhosis the world over. And it is so common that I think the physicians or the clinicians or the diagnostic people who will be there in the audience, they will agree that uh, a condition, fatty liver, is probably seen every day. Every day they must be coming across patients who have got a fatty liver, and hardly a day passes when they don't see such a patient. So this is what it is. Today we are talking about fatty liver, a disease which is very common these days. And I think it would not be a wrong statement to say that there is a global epidemic of fatty liver all over the world. So let's see how we approach these patients. how do we really go about working before we start treatment, and before how do we work up these patients? And that is my topic today, approach to a patient with fatty liver. But before I go to actually how to approach these patients, I would like to tell you a little bit about the background of this disease, the pathophysiology, the epidemiology, because that probably will help us in understanding how to approach these patients. So coming firstly to my first slide, the slides are not moving, please. Yeah. Now this is a typical representation of a patient, who can have a fatty liver. You see a middle-aged man who's definitely obese and who's got a very fat belly. And this is the patient who's probably has diabetes also, and probably has dyslipidemia also. And this is the patient who is the most likely to have a fatty liver. Now, as you know, that this patient typically represents a patient of what we call as metabolic syndrome, and this patient is actually a walking time bomb. Although he may seem very happy, but he is a walking time bomb who can explode anytime. He can explode from the cardiac side. He can explode with the CAVA. He can explode from the diabetic side. And now we know that this patient can also explode from the liver side. So the liver involvement in this overall metabolic syndrome is probably as serious as other involvements. Next slide, please. Now, coming first to the definition of fatty liver. The definition is very simple. It is basically an intracytoplasmic accumulation of triglycerides in vesicular form in greater than equal to 5% of hepatocytes. So if 5% of hepatocytes have got fat in it, accumulated in it, it's a fatty liver. Or the alternative way to put it is that fat content of the liver is about 5% of the total weight of the liver. So this is how we define fatty liver. Now, fatty liver, next slide. It can be caused either by alcohol, or it can be a non-alcoholic fatty liver disease. So these are the two broad subsets of fatty liver disease, of which I would be talking about the non-alcoholic fatty liver disease, because alcohol-induced fatty liver disease is a separate topic altogether. Next. So this non-alcoholic fatty liver disease, basically it is a disease in which there is, as the definition says, there is fat in the hepatocytes. And the histology is very similar to what we get in an alcoholic liver disease patient. But this patient does not take alcohol. So that's why the word non-alcoholic fatty liver disease was there initially. It is still continuing, but it is going to change very soon, because a connotation alcoholic, it has got its own stigmatas. So nowadays, there has been an international working committee which has changed the nomenclature of this disease. But for the sake of continuity, and because all the literature which we have is on non-alcoholic, with this term non-alcoholic fatty liver disease, in this particular talk, I'll be using this term. But very soon, probably the name is going to change to metabolic associated fatty liver disease. Next. So now you have to understand, this fatty liver disease is a big set, it's a huge set which includes different patients with different severity of the disease. And this severity is basically based on what their liver histology shows. So a fatty liver patient can be a patient who has simple steatosis on histology, which is, the pure form of fatty liver disease, in which there are only lipid droplets. But gradually, because of the presence of this lipid, there will be inflammation. And then it will become a combination of lipid plus inflammation, which we call as steatohepatitis, or non-alcoholic steatohepatitis, or NASH. Then gradually this inflammation will lead to fibrosis, when the combination will become of steatohepatitis plus fibrosis. And lastly, this fibrosis will lead to collapse of the liver architecture, and we'll get a full-blown cirrhosis, when we will get what we call nowadays as NASH-related cirrhosis. So all the four severity stages come in this overall term non-alcoholic fatty liver disease. Next. Now, why these severity stages are important, because we know as the patient progresses from fatty liver to steatohepatitis to fibrosis to cirrhosis, his morbidity and mortality obviously increases. So that's important. That's why it is important to know at which particular stage a particular patient is, because his morbidity and mortality will depend on that. Next. Now, if we come to the epidemiology of NAFLD, this is a disease, which has now, as I told, become the most common cause of chronic liver disease in many countries across the world. It is not only in Asia, but Europe, North America, Middle East, everywhere. Everywhere it is becoming the commonest cause of liver disease, especially because hepatitis B and C, and now, they have been controlled to a large extent. So now this has become the major cause of liver disease all over the world. And next, next slide, please. Yeah. One of the very basic tenet of this disease is that NAFLD is associated with metabolic syndrome. Now, you all know what is a metabolic syndrome. It is basically a disease syndrome where you have obesity, hypertriglyceridemia, hypertension, diabetes or impaired GTT, and dyslipidemia in form of low HDL or increase in cholesterol or triglycerides. So this is a metabolic syndrome, and there is a strong association of NAFLD and metabolic syndrome. So 90% of NAFLD patients will have at least one feature of this metabolic syndrome. Either they will be obese, or they'll have dyslipidemia, or they'll have hypertension, or they'll have impaired GTD. Something or the other of the metabolic syndrome would be there. Next. 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 So now probably, we can confidently say that NAFLD is also a part of this metabolic syndrome, and it is the hepatic manifestation of this insulin-resistant syndrome or metabolic syndrome, which we call. So we knew its cardiovascular components, the diabetic component of metabolic syndrome we knew, and probably liver is the fatty liver is the liver component of this syndrome. Next. Now coming to some figures to show what is the association. 80% of NAFLD patients have increased BMI. About 30 to 40% are obese. 50% of these NAFLD patients will show insulin resistance on investigations. 80% of them will show hyperlipidemia. And 30 to 60% have got arterial hypertension. So this strong association of components of metabolic syndrome with NAFLD, they are there, they are universal, and they are seen all throughout the world. The association with diabetes is also very strong. Next slide, please. And if you see the figures, about 40 to 70% of diabetes patients will have a fatty liver. 20 to, or in putting in the other way, 20 to 30% of fatty liver patients will have underlying diabetes. And it has been seen that diabetic patients who have fatty liver, they have a higher cardiovascular mortality and morbidity as compared to patients who do not have fatty liver. So there's a strong association between fatty liver and diabetes also. Next. Next slide. Coming to a very interesting entity which is known as lean NAFLD. Now, as you have seen, that majority of the patients, that I already said, about 80% of the patients of NAFLD will be overweight, and about 50% of them may be probably obese. But then there is still a subgroup of patients who are very lean and thin, but who have fatty liver. So these patients have been called as patients having a lean NAFLD. This type of, these type of patients are more common in our Asian population as compared to a Western population, where the increased body weight or obesity is even more common. But even in Asia, if we see that some of these patients will not be overweight or obese as per, according to the BMI category or the weight per se, but they may be metabolic obese. And by metabolic obese, I mean that they may be carrying central obesity. The overall weight may not be high, but they may be obese from the mid body the mid body circumference would be more, or they will be having an insulin resistance, although the weight has not increased. So we should also keep this in mind that not all the patients of fatty liver are going to be fat. There is a subset which is known as lean NFLD also. Next slide. Now, is the central visceral obesity a risk factor for NFLD? Yes, it is. Next, it definitely is. Next slide. Visceral obesity, has got its own mechanism by which it causes NAFLD. So it's visceral obesity which is more important, or the central obesity which is more important as compared to the overall weight of the patient if he has to develop a fatty liver. Next. A very, next slide. Next slide, please. Next slide. Can we go on to next slide, please? Yeah. A very, I would say alarming thing about NAFLD is what we called as pediatric NAFLD. You see, the age is no bar for having a fatty liver. And even small children nowadays, we are seeing a lot of, children carrying an ultrasound report where they have fatty liver. The prevalence is pretty high, 2 to 17% in different studies. And in adolescents, it becomes even higher, with the incidence ranging from 10 to 77%. This is something I think which is very alarming, because these are the patients who are going to live pretty long, and during their lifespan, this fatty liver can transform into a steatohepatitis or later on to fibrosis or cirrhosis. And I think it is quite important to intervene in these patients from very young to protect their liver. So these are some alarming figures of pediatric NAFLD. Next slide. Yeah. Now, I will not go into the detail of pathogenesis of NAFLD because that's not my talk today. But the main thing to remember is that insulin resistance probably is the key component in the pathophysiology. Things start from there. And this insulin resistance in the muscle results in hyperglycemia, and due to inability of the cells to utilize glucose. In the adipose tissue, this insulin resistance leads to excessive release of free fatty acids, which are reaching the liver and thereby causing a fatty liver. And in the liver itself, this insulin resistance causes an increased rate of de novo lipogenesis and a reduced rate of beta oxidation by the hepatocytes. And all these factors then lead to development of fatty liver disease. So I think that this is just one slide pathogenesis, although we can have a full topic on pathogenesis of NAFLD, but this is a one slide representation of pathogenesis of NAFLD. Next slide. Is it a genetic disease? Yes, we see familial clustering, and probably in some of these families, there may be obesity which is running in the family. There may be hypertriglyceridemia which is running in the family. Cholesterol, hypercholesteremia runs in the families. So there is some genetic component, but obviously the environment insults are also important. A person who leads a very sedentary lifestyle, is not careful about the diet, puts on a lot of weight, this patient is likely to develop NAFLD, whether he is genetically predisposed or not. But in a family, does a positive family history influence the severity? This we don't know, but this is an important concept. Suppose we have one person in the family who has a lot of morbidity and probably mortality due to fatty liver disease. It is important to caution the other patient, but we are not, we don't have too much data on this. Next slide. Now, coming to the natural history of NAFLD, you see it's a slow disease. From a normal liver, if you get a fatty liver, it takes about 10 to 20 years to progress from fatty liver to NAFL to steatohepatitis, and then to fibrosis, and finally to cirrhosis. So it's a slow growing disease. Slowly from fatty liver, one develops steatohepatitis, and from there one develops fibrosis and cirrhosis. The interval is about 10 to 20 years. And once a person develops cirrhosis, then like any other cirrhosis, in 3 to 6 years' time, he is going to decompensate. And once he is decompensated, then in 1 to 2 years, either the patient will not survive due to complications of cirrhosis, or he may develop a hepatocellular carcinoma and eventually he may die because of it. So fatty liver is not all that benign, but I would not scare everybody. It's not benign, but then it is a slow growing process also. It's not a very rapid overnight disease which can cause any catastrophe. Next slide. Next slide, you can skip this. Next slide. Next slide. Okay. Now coming to the etiology of fatty liver, as we have seen that majority of them are going to be associated with metabolic syndrome. Majority of the patients, more than 80 to 90% of the patients are going to have a fatty liver. If you see, 80 to 90% of them will be part of the metabolic syndrome. But there can be other causes of fat accumulating in the liver. So technically, then there can be other etiological causes for NFLD also. And surprisingly, the other causes are malnutrition and starvation. So too much of food is bad, and too little of food is also bad, because it can lead to the similar consequences in the liver. So even a malnourished or a starved person can develop a fatty liver disease. Next. The other causes of fatty liver as such can be, next slide, are drugs. There are certain drugs which as a side effect can cause fatty liver. And the important in the list is the cytotoxic drugs, steroids, estrogens, amiodarone, tamoxifen, tetracycline, hydroxyzine. Why I'm telling you this is basically, once we talk about the approach, which we are going to talk very soon, when we take the history of these patients, it's important to find out if he's on any of these drugs. Next. Next slide. Now, there are some other miscellaneous causes of fatty liver. Total parenteral nutrition, that's one of the causes of fatty liver. Small gut bacterial overgrowth is associated with fatty liver. Severe anemia is associated with fatty liver. Fatty liver can be seen in Wilson disease. And a high fructose intake or too much of intake of aerated drinks has also been linked to fatty liver. Next. Now, coming to the symptomatology of NFLD. Now, majority of the patients, are asymptomatic. They will be having a fatty liver, but there will be no symptoms because of that. And even if they have some symptoms, the symptoms are very non-specific. For example, a pain in the right hypochondrium, some vague fatigue or malaise, no specific symptoms which can, by symptomatology, we can pick that this patient has got a fatty liver. So then how do we encounter a patient of fatty liver? Let's see that. 3 ways, because symptoms are not there. So how does the patient come to us? Next slide. There are 3 ways, in which we will encounter a patient of fatty liver. One, patient got an ultrasound done. This is a very common scenario. A patient gets an ultrasound done for some cause, and the ultrasound shows fatty liver. So this is the commonest way when patient, and then the patient comes to us as physicians or gastroenterologists that I have got a fatty liver, know what to do. Second is, during a clinical examination, you pick up a hepatomegaly, and then in further workup of hepatomegaly, one finds that the patient has got fatty liver. And third, very common cause these days is then patient got a routine blood biochemistry done as a part of an annual health checkup or a pre-employment health checkup, and they were raised transaminases. And from there, the story started, and from further investigation of transaminases, it was found out that probably this patient has got a fatty liver. So these are the 3 common ways in which patient will come to us. Next. So now, actually coming to the approach to these patients, once this pathophysiology and these associations are clear, the approach becomes very simple. And there are 3 main things which we need to do when the patient comes with a report of fatty liver. First of all, we have to find out the cause or the basically the associated comorbidities, which I told you are very common in these patients. So we have to look at that. Second important thing for prognosis and treatment of patient is to assess the severity of liver damage. Whether this patient is just a bland fatty liver, or he's having inflammation in the liver, or he's full-blown cirrhosis. So we need to know that. And third, obviously, is to start the treatment, which is not the topic today. Next. Next slide. So starting to work up these patients, First of all, the history. We have to take a history of diabetes, hyperlipidemias, hypothyroidism, hypertension. As I told you, some of the common drugs cause fatty liver. So take a drug history, watch our drugs patients is he on steroids, is he on estrogen hormones. We have to look at that. Is there any past history of surgery? That is important. If, because many of these, these days patients who undergo bariatric surgery and all, they've got a fatty liver. So we have to ask the history about that. Food, going into the dietary habits, is also important because that will help us in counseling our patients later on, and intervening in them with therapeutic measures. Next. Next slide. Coming to clinical examination, there's nothing much except that we have to look for obesity, and in the, if the patient comes in an advanced stage, then obviously we will have a look for any signs of chronic liver disease, stigmata of chronic like ascites, spider angiomas, splenomegaly, palmararrhythmia, and the others. Next. So after history and exam, next slide. Next slide, please. Now we start investigating these patients. When we have taken the history and the clinical examination, we start investigations. Now, investigations are basically, we can divide the investigations in three important categories. One is for diagnosis, which, as I told you, most of the time would already have been done. The patient would have the ultrasound report. But yes, for diagnosis, we need investigations. Second is to find out the etiology. And third is for assessing the severity. So I think this makes the approach very simple, that you take, when a patient, you take a detailed clinical history and and do the clinical examination, and then you start investigating these patients, and the investigations can be divided into diagnosis, etiology, and assessing the severity types. But now coming first to the diagnosing part. Next slide. Now the most important thing, the most important investigation for diagnosis is, as you know, is ultrasound. Either the patient would already have it, will come with that, or you have to get the, if you pick up a hepatomegaly, you have to get an ultrasound done. This is very simple, cheap, easily available investigation. And in this can very easily pick up fatty liver. And usually the features on ultrasound are presence of a bright liver, increased ecotexture compared to kidneys, and vascular blurring. So these are the features which, tell a clinician, tell a radiologist that probably this patient has a fatty liver. Next slide. And next slide, please. Generally, the radiologists try to classify these patients into mild, severe, or focal, or grade 1, grade 2, grade 3 fatty liver, depending on the, the extent of hepatic involvement which they can see on the ultrasound. Next. Next. Now, although ultrasound is a very good modality, it is very cheap and easily available modality, but there are certain limitations on ultrasound. One important limitation is that ultrasound has got a sensitivity that it can pick up fatty liver when more than 30% of the liver is replaced by fat. And we know by definitions, if it's more than 5%, it's a fatty liver. So these initial mild cases, these are some things which which is something which can be missed by ultrasound. The sensitivity is not so good in the early stages of fatty liver, but as the fat advances, then obviously it becomes easy for the ultrasonologist to pick up fatty liver. Second important limitation of ultrasound is that it can pick up a fatty liver, but it cannot differentiate whether this patient has got a underlying, along with fatty liver, a steatohepatitis or fibrosis. That is something which ultrasound cannot pick. Obviously, if it has become advanced to the stage of cirrhosis, then obviously the changes can be picked up. But changes of NASH and fibrosis cannot be picked up. And because of this limitations of ultrasound, the other modalities were also tried to, in this condition. Next slide. And, CT scan, MRI, spectroscopy, all these were, studied in this disease. They are all, one slide before. Can we go to the previous slide, please? Previous slide. Previous slide. Okay. Basically, yeah. You see, the CT scan, MRI spectroscopy, these have been studied in fatty liver patients. Although CT scan and MRI, they increase the sensitivity, and the best is MRI spectroscopy because it increases the sensitivity to pick up a fatty liver and to give, a better quantification of how much of liver is involved. But again, that limitation of not being able to differentiate pure fatty liver from steatohepatitis and early fibrosis is something which even these investigations were not able to do. So unfortunately, by radiology, we can pick up fatty liver, but we cannot pick up categorize these patients into further subgroup or pick up the severity of fatty liver is not possible with most of the radiological imaging studies. Next. Next. So next important thing in workup of this patient is obviously to get a LFT, because the fatty liver, we want to know what are the liver function tests. And in fatty liver, about 50% of the patients who have steatosis, they will have some slight subtle abnormalities in the liver, function test profiles. But if the stage has progressed to NASH, then almost 80% of the patients will have got some abnormality of the liver function tests. And the most common abnormality which we see is that AST and ALT, they are raised. They may be raised up to 4 to 5 times of normal. They're not raised as high as you see in viral hepatitis, but about 1 to 4 times of normal you will say raised ALT and AST. Initially, ALT is more than AST, and but as the disease progresses and patient goes into cirrhosis or advanced cirrhosis, then probably the ratio will reserve and AST will be more than ALT. Otherwise, initially the ALT is more than AST. The other parameters of liver functions like bilirubin, albumin, prothrombin time, these remain normal till very late in the disease when the patient has become cirrhotic. Otherwise, in the early stages, this is not going to help us and they are going to remain normal. Next slide. Next, as I said, once we have diagnosed that patient has got fatty liver on ultrasound, and then we have done his LFTs, the next important step is to find out the etiology behind this fatty liver. As I said, that the most important thing is to look for the various components of metabolic syndrome in these patients, and for that we will get a blood sugar done, fasting PP, a hemoglobin A1C should be done, a lipid profile should be done, as because I said about 70 to 80% of the patients might have dyslipidemia along with fatty liver. Serum insulin levels have to be done. Then thyroid, as I told you, is another condition in which fatty liver can occur. So it's good to screen for thyroid, and thyroid function tests should be done. And I think this is an important point to screen these patients for HbS and anti-HCV also, because sometimes, especially hepatitis C, can initially have a histology in which there is a lot of fatty liver, So sometimes early manifestation of these diseases could be fatty liver. And so it is good to screen for HbS, AG, and anti-HCV in these patients, especially if they have raised transaminases, because both the diseases can coexist also. So in the investigations after LFT, we get a blood sugar done, lipid profile, thyroid profile, serum insulin, and hepatitis markers B and C for hepatitis B and C. Next. Next. Now, the important thing comes, once we have diagnosed, and then we want to know the severity. And as we have seen that none of the previous investigations were able to tell us what is the severity of the disease, how much is the liver damage, which is our prime concern. That is probably not, clearly shown by the rest of the investigation. So for which we have to move on to liver biopsy, and liver biopsy is the gold standard for picking up the severity. Next. Next. And liver biopsy, you see the various stages of fatty liver can be seen: steatosis, hepatocyte ballooning, lobular inflammation, and fibrosis, depending on which stage the patient is, that we can find out. Next. Next. These are some slides which I think most of the pathologists in the audience would be familiar. This shows steatosis. Next. Next. The classical hepatocyte ballooning, which we see because of fat, early fibrosis. Next. And then advanced cirrhosis. This is the kind of histology which we would see depending on the stage of the patients. Now, as we say that liver biopsy is the gold standard for diagnosing the severity of this disease, but the problem, there are a lot of limitations with liver biopsy also. Number one, it examines only a very small 1:50,000, thousand specimen of the liver. It is an invasive investigation which has got its own complications. Even mortality has been associated with liver biopsy due to complications. So it's an invasive test. And thirdly, and lastly, the disease distribution in fatty liver may be patchy. And we are, taking a very small sample. So fatty liver can be missed, or its severity can be missed if the disease is patchy. So liver biopsy has its got own limitations. So there was always an interest that we need something. There was, there was this short gap that we need something that which can tell us about this fibrosis, and without the help of without the help of biopsy, if we can do something non-invasive and get to know. So there was certain, there was research on this, and two things came up. Next, two non-invasive ways of finding out the severity of liver disease, and these were the biomarkers and fibroscan. Now coming to biomarkers, biomarkers are basically, blood, markers which may indicate underlying inflammation, which may be, which may tell us that there is cell apoptosis which is going down, or oxidative stress which is going on, which may also indirectly tell us that there is fibrosis which is going on in the body. And obviously fibroscan I'll be talking about in 2 minutes. Coming first to biomarkers, we have biomarkers for inflammation. For example, a decreased adiponectin, or increased CRP, or increased IL-6. But as you know, these are all very non-specific markers, and they may be high in any disease, any inflammatory disease. These will become high or low. So whether this are because of fatty liver, it's very difficult to say. Next. Next. Then we have biomarkers for oxidative stress, like increased glutathione, increased malondialdehyde, increased NO. Again, in a fatty liver patient, if these are high, indirect evidence that there is some oxidative stress going on, probably in the liver, but again, not too sensitive, not too specific. Next. Next. Then we have biomarkers for fibrosis, like hyaluronic acid, laminin, and ferritin. These can also guide us. If they are high, then we know that some amount of fibrosis is going on somewhere in the body. So this can help us in making some sort of prediction. As you have seen that most of these biomarkers in an individual capacity are, are not going to help us, because they are so non-specific. The sensitivity we don't know, and it is very difficult to, on the basis of a single biomarker, say that what is the stage of this patient. So what people tried was, they took do a combination of 3 to 4 or 5, 6 biomarkers, and they did research, and then they came out with certain scores based on this group of biomarkers, and that probably has got more accuracy in predicting that which stage the patient is. It can pick up fibrosis and all. If we have 5, 6 biomarkers and a composite score based on that, and this you will see in the next slide. Next, there are certain scores which are available next based on these biomarker combinations, like BART score, ELF score, or a fibrotest score. These are a fibrotest score is available in our country also, and we can get it done. And based on the biochemical markers in the blood, they can tell us to a reasonable level of accuracy that this patient is probably having significant fibrosis or not in the body. So another important innovation I said was FibroScan, which is a very beautiful tool these days, a very easily available and a good tool. It is based on transient elastography, which uses ultrasound to quantify liver stiffness and estimate fibrosis. Next. Next. It's a very simple portable machine, although very expensive, but otherwise very user-friendly and a portable machine. Next. Next. And it is done just the way patient gets ultrasound done. And this is one of the typical reports of what you will see, that it tells us about the amount of fat, with the CAP values, and more importantly the E value, which tells us the amount of fibrosis. Any E value above 8 is significant. Anything between 8 to 12 shows that there's significant amount of fibrosis, and beyond 12, if this value is, it is a very good predictor of telling us that probably this patient has got cirrhosis. Next. Next. So the advantages of FibroScan are that it is non-invasive, it can assess a large area of liver, unlike biopsy, and it can allow multiple. It's non-invasive, so it can allow us multiple readings after intervention, before treatment, after treatment. But the disadvantage of FibroScan is that the readings can be falsely high in very obese patients. It's very difficult to get a good FibroScan in those patients, and many of these patients are going to be very obese. Secondly, inflammation, if it is there in the liver due to any other cause, that can be an artifact. And cost is now reasonably not that high because of increased availability, but it's still, for some people it may be high. So these are some of the limitations of FibroScan. Otherwise, it's a very good non-invasive tool in screening these patients. Next. Next. So should it be get in all patients? I think gradually this would be the scenario when the cost is not so deterrent. So, but till then, yes, special group patients definitely. For example, patients who are morbidly obese, patients who have got signs of liver cell failure, cirrhosis, patients who have got competitive etiologies, they are confused whether, along with fatty liver, they are also HbS positive, anti-HCV positive. So two etiologies is very important, always important to know whether the patient has got significant liver damage or not. And then obviously to monitor therapy and response we have started. Then these are the patients where we should get a FibroScan done. Next. Next. So just summarizing, if the approach to NAFLD patient, if a patient of NAFLD comes to us, if a patient comes to us in which we are suspecting NAFLD, then we have to take a detailed history and clinical examination. We have to investigate him, confirm his fatty liver on ultrasound. If required, not so sure on ultrasound, then we can go in for CT scan or MRI, and then investigate him for his metabolic risk factors. And this includes blood sugar, fasting and PP, lipid profile. And then further, we have to look for any competing etiologies like HbS, AG, anti-HCV, thyroid, and obviously serum insulin in these patients can be tested. Then these patients can be subjected to FibroScan to know the severity of their liver disease. And liver biopsy obviously is not something which we can do in routine, only in special group patient where we need to know the definite diagnosis or definite evidence of cirrhosis has to be seen. So I think by this, you see the approach to NAFLD is not all that difficult. If we know the background and the pathophysiology, a systematic approach, we can work up these patients, and then we can take them for interventions and treatments and lifestyle modification, which obviously is a separate topic which we are not discussing these days. Thank you. So I think that
Ma'am, you can start your screen sharing. Sir is not present. It's a recorded video only.
Yes.
मेरा स्लाइड था अब ये लेटेस्ट है 6-4 वाला है शार्प
ये मैम ठीक है
चलो आई स्टार्ट स्पीकिंग वेयर इज माय फोटो
ये तो इससे पढ़ा रहे हैं ना ये
हेलो गुड आफ्टरनून हेलो
Yes, ma'am. Good afternoon.
हेलो हाँ गुड आफ्टरनून may I start the lecture?
Yes, ma'am.
Okay, so before I start, I would like to know how many postgraduates are sitting in the audience. How many are postgraduates? Any postgraduates, please speak, say yes, no. Hello? Or any junior consultants? Hello? My screen is visible?
Yes, ma'am, your screen is
Hello?
visible. Just make it full screen.
I have made it full screen.
No, ma'am, you have to share your screen, not the PPT. You have to share the entire screen.
Okay, 1 minute. They are the one. Only 3 people are sitting.
94.
24 participants are there. No, that's me. Hello, can I send you my slides?
Yes, now open your presentation.
Hello?
Now open your presentation.
Can you see my slides now?
No, ma'am.
Is it? It's open. Can you see it?
No, ma'am.
So should I send you my?
Yes, you can.
Which number I should send? Dr. Neeraj Jain number, or there is another number for slide sending? Can you see my slides now?
Its slides are visible, but it's not in full screen mode.
अभी full screen में आया?
नहीं, मैम.
तो मेरे को तो यहाँ full screen में दिख रहा है.
मैम, आपने स्क्रीन शेयर में आपने अपनी सिर्फ प्रेजेंटेशन शेयर किया हुआ है. आपको अपनी स्क्रीन शेयर करना पड़ेगा. आपको मैं बता देता हूँ. आप स्टार्ट दोबारा से एक बार स्क्रीन शेयर स्टॉप करके करेंगे तो एक बार स्क्रीन शेयर स्क्रीन पे आप क्लिक करेंगे.
बताइए क्या शेयर स्क्रीन मैंने दबाया है?
ठीक है. अभी टॉप रो में आपको बेसिक एडवांस
हाँ, किया
फाइल्स
है.
दिख रहे हैं.
क्रोम
बेसिक
टैब
पे
आ रहा है,
आप
विंडो आ रहा है, इंटायर.
सर आप बेसिक पे क्लिक कीजिए.
बेसिक
जी.
नहीं, यहाँ पे मुझे क्रोम टैब आ रहा है, विंडो आ रहा है, इंटायर स्क्रीन आ रहा है.
विंडो एंटायर स्क्रीन को आप क्लिक कीजिए.
हाँ, इंटायर स्क्रीन
एंड
किया.
देन शेयर.
अब आया?
शेयर पे क्लिक कीजिए सर.
अब आ रहा है इंटायर स्क्रीन.
यस.
हाँ,
अब
किया
आप
है.
फुल स्क्रीन कीजिए.
अभी दिख रहा है आपको
नाउ इट
पूरा
इज
पीपीटी?
यस. यस सर. इट्स परफेक्ट नाउ.
No, it's fine. Okay.
Yes, ma'am.
So am I audible also?
Yes, ma'am.
Any postgraduate students? There are postgraduate trainees. Okay. So my question to them is, what is their concept about pregnancy-induced hypertension? Anyone? Anyone, please? Okay. So I'll start my lecture. So I shall be discussing in this lecture about pathophysiology of preeclampsia, the systemic consequences of preeclampsia, screening, which is upcoming nowadays, which are the women who are likely to develop preeclampsia in the later part of the pregnancy, and the diagnosis. Now, the pathophysiology of the preeclampsia, it's basically a placental disease. And this picture very well shows that how the syncytiotropoblast and cytotrophoblast villi gradually start invading the decidua and then to the myometrium. So these cells invade the spiral arterioles in the decidua first, in the 8 to 10 weeks of pregnancy, and gradually in the second wave, they also invade myometrial the part of the spiral arterioles which is there in the myometrium. And in this process, they replace the endothelium, the vascular endothelium, and also the musculoelastic layer. And as a result, the vessel becomes very dilated. There is a high perfusion and also the more tortuous. And this is how the more blood goes to the placenta and hence to the fetus. So this is in the normal implantation process in a normal pregnancy. But what happens in pregnancy-induced hypertension? These cytotrophoblasts and syncytiotrophoblasts, they do invade. They do invade the spiral arterioles, but they do not invade completely, and they do not invade the part of the spiral arteriole which is there in the myometrium. And as a result, there is a absence of dilatation of the spiral arterioles, and therefore there is a hypoxia. Now, this hypoperfusion and hypoxia leads to stress on the syncytiotrophoblasts. In this picture, you can see that these cells are stressed. And as a result of the stress, they start releasing a lot of cytokines and anti-angiogenic factors and vesicles into the maternal circulation. Now, because of this, there is an imbalance between the angiogenic factors and anti-angiogenic factors. So if I see in this picture, we can understand this into two stages. First stage is that there is some risk factor present in the mother, either genetic or environmental, like immune, like patient is obese and she is already a patient chronic hypertensive or many other factors. She's diabetic, she's having Aplar syndrome, she's primigravida. So there are a lot of environmental factors too. Some immune factors and metabolic factors. So in this scenario, in this presence of the risk factors, there is an abnormal trophoblast development. Okay. Now this abnormal trophoblast cannot fully invade the spiral arterioles, and as a result, there is a decrease in the blood flow to the placenta, and therefore there is a ischemia. So this is stage 1. Now, once there is a ischemia, there is a disbalance between the proangiogenesis, anti-inflammation, which is required during the pregnancy. It gets converted to anti-angiogenesis, pro-inflammation, and therefore the vascular endothelium of the maternal vessels is affected and there is a dysfunction of the endothelium. Now, when the vessels of the endothelium are affected and they are dysfunctioning, this results in the systemic organ failure or organ dysfunction. So in this slide, it is more clear. So here is the normal pregnant woman who has a normal spiral arteries, normal invasion of the cytotrophoblast, normoxia, and there is no resistance to the blood flow. Rather, there is an increased blood flow, and therefore the placental growth factor is high as compared to these anti-angiogenic factors, that is SFILT1 and serum endoglin. So these are decreased and this is high. So this is the normal angiogenesis. Whereas in a pregnant woman with preeclampsia, there is an abnormal spiral artery remodeling, there is a reduced cytotrophoblast invasion, there is a placental hypoxia and ischemia, oxidative stress, decreased blood flow, and as a result, all these anti-angiogenic factors are on an upper hand as compared to the placental growth factor. Is it clear to everyone? Okay. So just in short, so it is basically preeclampsia is a placental disease. It causes the damage to the endothelium of the maternal blood vessels and hence the organ failure. And these are the inflammatory cytokines and free DNA, RNA, proteins which are released into the circulation of the mother because of the stress of the syncytial trophoblast. And these are the ones which are the area of screening, which help in the screening. Okay. I'm sorry this slide is not coming, but this was probably a repetition. So now as a result, now since we have seen that there is a vascular endothelial injury in all the maternal blood vessels, and therefore the blood vessels supplying different vital organs start getting damaged and hence cause the organ damage. So it can affect the heart of the mother, pulmonary, the lungs of the mother, the liver, the hematological dysfunction, which we will be discussing later on, high blood pressure, fetal growth restriction, renal failure or kidneys are affected, and brain. So what are the effects it produces on the different organs? In the brain, it causes eclampsia. It can cause eclampsia, hemorrhagic stroke, seizures, visual disturbances, cortical blindness, and then cerebral venous sinus thrombosis and severe headache. In the lungs, it can cause pulmonary edema. In the vasculature, it can cause coagulopathy, thrombocytopenia. All these things I'll be discussing. And this is how these are the effect. This is only we have to pick up by the lab tests. In the liver, it can cause HELLP syndrome, severe liver dysfunction, which is little rare, but it can happen. Kidney, again, it can cause proteinuria, renal failure. Placenta, it can cause abruptio placentae, placental dysfunction, hypoxia, leading to intrauterine growth restriction, which is here, and inadequate remodeling of the vessels in the decidua. So this is all effects it can cause. It is a multi-organ dysfunction, and we have to screen each and everything in a woman who presents with pregnancy-induced hypertension. So what happens in the normal pregnancy? There is an increase in the plasma volume and increase in the cardiac output. There is a decrease in the systemic vascular resistance, and hence the blood pressure falls, and all these, there is activation of the RAS. Because of the increase in the plasma volume, the cardiac output, and the renal blood flow, the renal plasma flow, which increases up to 70% more as compared to the non-pregnant women, there's an increase in the glomerular filtration rate of 50%. As a result, the serum creatinine and the blood urea decreases due to this hyperfiltration. Therefore, the mean serum creatinine levels during pregnancy drops to 0.5 milligram per dl, whereas in the non-pregnant, the mean creatinine level is 0.7 milligram per dl. So this is very, very important while we are interpreting any report which we get from the lab for the pregnancy-induced hypertension patient. So reading the creatinine level is very important, because the serum creatinine level of 0.9 milligram per dl or more suggests underlying renal dysfunction, whereas it is very normal for a non-pregnant woman, but for a pregnant woman, this will alarm to the obstetrician that there is something wrong with the renal functions. So this is very important. And for the lab medicine experts, this is very important, because once they give the report, it directs our diagnosis and treatment. So the accuracy of the report is very important. Similarly, we very often order for urine analysis. We know that glycosuria is normally present in the pregnancy because of the decreased renal threshold of the kidneys. The proteinuria, significant proteinuria during pregnancy is 300 milligram per deciliter instead of 150 in non-pregnant women. And this is also because of the changes, normal physiological changes, increased GFR during pregnancy. So what are the different tests we can measure the urine proteins. Anyone? Any of the postgraduates or junior consultants? Okay, so we all know that there is a qualitative method of classic dipstick and a quantitative methods, and the gold standard is 24 hours urinary collection. There is a misprint over here. One urinary word is missing. The spot urine protein creatinine ratio and spot urine albumin creatinine ratio. Now, this gold standard 24 hours urine collection, what are the disadvantages? The disadvantages that during pregnancy, there is an anatomically dilatation of all the renal tract. Because of that dilatation, there remains some residual urine, which might be lying hours before we start collecting 24 hours urine. Say we want to collect 24 hours urine from 9 a.m. today, but that residual urine may be lying before 9 a.m. So this will affect our calculation. So it's a long procedure of collecting, cumbersome. There are errors in collection. So these are the disadvantages of this method. Now the spot urine protein creatinine ratio, it measures the amount of protein excreted per unit of the creatinine in 24 hours. But it may not be constant all the time. There are times when there is more protein excretion. There are times, these are random excretions. So this may not be very accurate. There are qualitative methods like dipstick. Here the disadvantage is that the renal concentration and dilution of the urine is not accounted. So if there is a dilute urine and the test comes trace, so dipstick shows trace urine, proteinuria, so that may not be actually trace because there is a diluted urine. That's why it is taking as trace. So therefore, this method has also its own drawbacks. So now we move on to 24 hours urine protein versus the spot urine protein creatinine ratio. So the DAPA study in 2017 has compared these two tests of PCR, spot protein creatinine ratio and albumin creatinine ratio with the 24-hour urine collection. And they had shown that ACR had a significantly higher sensitivity of 99% as compared to 90% with PCR. And these two tests are very, very comparable to the 24 hours urine collection. Okay, so these are their standard, but they compared it with 24 hours urine collection and they found that these two tests are comparable. And nowadays we are doing ACR and PCR only. We don't do 24 hours urine collection because of the other problem errors. Now the NICE recommends that if the dipstick comes nice, so 1+, then we must order for ACR or PCR should be done to quantify the proteinuria. This is as per the latest guideline of the NICE in 2019. So now what happens to the liver function test in normal pregnancy? We all know that alkaline phosphatase increases and it becomes almost double from the level in the non-pregnant women. Now this decrease, there are certain enzymes which decrease during pregnancy because of hemodilation and many other reasons. And of these, it is the AST, ALT, GGT, and serum albumin. These generally marginally decrease during pregnancy. So these become less than 40 IU per liter, which is lesser than the upper limit of the normal non-pregnant women. So now we know that there are changes in the renal function, there are changes in the liver functions, and these can affect our diagnosis as well as what treatment we offer to these pregnant women. Now we come to the diagnosis as per the American College of Obstetrics and Gynecology 2020 practice bulletin. So these are the definition, that is the age-old definition of high blood pressure and proteinuria. This is the age-old definition we all have learned in our undergraduates and postgraduates and all. But what is the difference now? So this definition says that high BP and proteinuria is one criteria. Suppose proteinuria is absent, there is no proteinuria, there is only high blood pressure. Then what are the other criteria besides proteinuria which can be used to diagnose preeclampsia or to label a woman that she is suffering from preeclampsia? So the other criteria, that is, one criteria is high blood pressure, but proteinuria is absent. Now, what are the other criteria? The other criteria is thrombocytopenia, count less than 1 lakh, renal insufficiency, that is creatinine greater than 1.1 milligram per dl, or doubling of the serum creatinine concentration in the absence of the other end. Whatever she had before, she came with, say, 0.5 milligram per dl. And now suddenly I do her renal function test and the report comes 1 milligram per dl. So that is, although less than 1.1 milligram per dl, but since it has doubled from the baseline value, so it shows that there is a renal insufficiency. And if it is there along with high blood pressure, the woman is labeled as preeclampsia even in the absence of proteinuria. So elevated liver transaminase is twice to the normal. So if it crosses 70 IU, so even if the proteinuria is absent, there is a high elevated liver enzymes along with high blood pressure, it is preeclampsia. Same is other criteria, clinical criteria like pulmonary edema, new onset headache unresponsive to medication, and visual disturbances. So the role of the lab medicine expert is very, very important even in the diagnosis. Their reports is very pertinent for all of us, and also their role is very important even in the management. I'll show you in the next couple of slides. Now, a word about the HELP syndrome. What is HELP syndrome? HELP stands for hemolysis, and elevated liver enzymes, low platelets. Now, this is a very severe form of preeclampsia and it warrants immediate delivery. Here, the lactate dehydrogenase is raised more than 600 IU per L and heptoglobulin levels are decreased. And also, there are a lot of changes in the peripheral smear, which I think the people from the lab medicine know better than me. So, I have not written over here. So, which go in favor of hemolysis. So this is one of the very severe form which carries a lot of very high maternal morbidity and mortality, and we have to act very swiftly once we diagnose this condition in the mother. Now the Williams obstetrics, I have taken this from there, says that routine laboratory assessment of coagulation, that is prothrombin time, activated partial thromboplastin time, and plasma fibrinogen level are unnecessary to be done in the management of pregnancy-associated hypertensive disorders. These do not guide us much. However, if the platelet count is low, then of course we order these tests, but not routinely. Now, these are some of the pictures I've adopted from the Williams only. Here we can see that there is a subcapsular hematoma in a woman. This is the liver and this is the hematoma. And these are the patients who can present with severe epigastric pain, nausea, vomiting. And this again is a very severe form of preeclampsia. Now, this is a gross specimen of the liver where there is a periportal hemorrhage in the liver in a patient with severe preeclampsia. These are the brain hemorrhages. This is a sketch diagram where are petechiae in the brain in different parts of the brain. A CT scan picture which showing high signal lesions. These are the high signal lesion in the posterior lobe of the brain. And these are the women who can present with altered sensorium. They have got very high blood pressure. And these are very severe form of preeclampsia. So there we order MRI or CT. So this is one of the pictures. These pictures are just to show that how this disease involves different organs in the mother. and it can be so detrimental if not timely detected and timely treated. So what are the conditions? Generally, we keep these mothers on expectant management with blood pressure control, and we keep monitoring by the lab test like liver function test, urine analysis, kidney function test, peripheral smear, hematocrit, all these things we keep on doing. And the frequency of these tests depend upon the severity of the disease, whether we'll do it every third day or every weekly or fortnightly. So severity of the disease we decide. There is no fixed protocol. And there are certain clinical and laboratory conditions when we have to take an urgent decision for delivery of the baby. And here is the slide, and this also has been adopted from the American College of Obs-Gynae 2020 practice bulletin. So here some of the maternal condition, uncontrolled blood pressure means in spite of having good 3 antihypertensive drugs, if the BP is not controlled, then she's labeled as uncontrolled severe range of blood pressure, epigastric pain or the right upper quadrant pain, visual disturbances, myocardial infarction, stroke, HELP syndrome. So here comes the role of lab medicine experts. We need really good reports to take a decision and to safeguard the mother. Not only to save the mother, if the reports are wrong, we can unnecessarily cause iatrogenic prematurity to the baby, and that baby will suffer all its life. And therefore the accuracy of the reports is very, very important for us to take any vital decision. The new or worsening the renal dysfunction, so that I have already discussed. Then clinical sign of pulmonary edema, scissors, placental abruption. Then of course the fetal testing, fetal heart rate variability is poor, there is a bradycardia and other diastolic flow is absent in the umbilical artery of the fetus. And this is how we take the decision about the not keeping her in the expectant management. So I finish here. Any questions? Screen on करें. So any questions? If there are no question, then I'll close. Please respond. Should I close?
Just a second, ma'am.
Anyone on
I'm
the
checking
other side?
the chat box. No, ma'am. There is no question in the chat box.
Okay. Okay, fine. Thanks. Exit. Exit.
Thank you, Diagnostic Week. Thank you, Dr. Neeraj Gupta, sir, for inviting me for the talk. Am I audible now? And my
Yes, ma'am.
screen is,
Yes, ma'am.
okay. And my screen is also for a very pertinent topic, that is healthcare waste management, biomedical waste management rules and guidelines. If you look at these rules and guidelines, every amendment, every change, it focuses on the decreasing the yellow category of waste, that is the waste that goes for incineration or burning, which releases dioxins and furans, which can cause cancers. So that's the whole idea. That's the basic principle. And since Government of India is signatory to the Sustainable Developmental Goals in United Nations, waste management sanitation is an important sustainable developmental goal. So if we are talking of biomedical waste, in a healthcare setting, we need to take into account the biomedical waste, the plastic waste, the e-waste, the hazardous waste, solid waste, construction and demolition waste. That is the implication, the other waste they have on biomedical waste, because COVID-19 was a big eye opener that if you do not implement the solid waste management rules, what happens? Anything and everything touched by the COVID-19 patient is dumped as biomedical waste. So the knowledge of other rules is equally important, what implications they have on biomedical waste, whether you're working in a hospital or in a diagnostic center. So next slide. So if you look at the history of biomedical waste rules, it was only the Bhopal gas tragedy which came into focus, that, brought into focus that there wasn't any Environment Protection Act. And after that Bhopal gas tragedy, Environment Protection Act came into picture. Then the radioactive waste, the hazardous chemical waste, then plague came, and then there were two independent petitions filed in Supreme Court, one on the general solid waste, the other one on the biomedical waste. Biomedical waste of AIMS in Safdarjung Hospital, there were the bulk generator getting dumped in River Yamuna. So that was 1998 rules. Then of course, there were often the wake-up calls like the hepatitis B outbreaks, the INCLIN survey, the hepatitis C outbreaks, and this was the mammoth study on the waste management across state, where the waste management was deficient. And of course, you often go through these reports of various needle stick injuries across Indian subcontinent, the quacks, how they are able to inflict the HIV by reuse of needle and syringes. And last but not the least, COVID-19 was a big eye opener that if you do not implement the solid waste rules, what happens to the biomedical waste? And so healthcare waste is covered under various rules and acts like the biomedical waste rules, the solid waste rules, the radioactive waste rules, the hazardous chemicals, e-waste. Now, what are the important implications the e-waste they have on the biomedical waste? What are the automated equipments, what you're using in your labs or in your diagnostic centers or in your hospitals? They need to be covered under the e-waste, the automated equipment and their computers, etc. So of course, we have the legislations and the guidelines like the biomedical waste rules, the solid waste rules. We have the national guidelines on infection prevention control. And then we have the CPCB guidelines, Ministry of Environment rules and the amendments, the Kayakalp guidelines. But you need to have your own policy as far as the waste management is concerned. If you look at the solid waste management rules, any healthcare facility with more than 5,000 square meter, they set up on site the compost plant apart from the gila and the suka kachra. That is, the green for the biodegradable and the blue for the plastic recyclables. You need to have adequate number of these bins inside, outside the hospital also, if your hospital is big, like for example, AIMS, Safdarjung Hospital, LNJP, Lady Harding, they're all bigger hospitals. So they have hospital inroads also. So hazardous waste. If you look at the hazardous waste, like you have the lead waste, lead apron, goggles, shields, they are there in the radiology department. They are covered under the respective rule by the government approved vendors by the State Pollution Control Board. Mercury, though many states are mercury free, but still is being used in many hospitals. So you need to have a mercury free policy also, and you need to have, there are other policies also, like if you're having mercury in your biosafety hood, if it spills, if it is broken, if it spills, then how it should be contained. There should be a mercury spill kit for that, and decontaminated with 10% sodium thiosulfate. And so these are the various policies. And then we have the radioactive waste management rules. The radioactive waste means which is generating radio waves. So if you're using any isotope, especially in the nuclear medicine department or in the radiotherapy department, you need to contain that particular radioisotope medicine for 10 times the half-life of that particular radioisotope. Contain it for 10 times. If the duration is 1 week, so 70 days, 10 times the half-life. After 10 times the half-life, treat it as normal biomedical waste. E-waste is covered under extended producer responsibility, wherein you give it back to the manufacturer. So all the automated equipment, whenever you're buying, please have in your rate tender contract the buyback policy. E-waste, this is our e-waste dump site. If you're a large hospital, have an authorization for e-waste also. And this is the plastic waste management rules, which state that biomedical waste disposal bag or any disposal bag, they need to be from 50 micron to 75 microns. So apart from the infectious diseases, you have like hepatitis B, hepatitis C, hepatitis D, you have transmission transmitted viruses. You have other things also, like the endocrinal disruptions, the chronic heart and lung diseases, exposure to radiation, fires, cancers, and malformation, air, land, and water pollution for not only this generation but generations to come. Antibiotic residues are reported in wastewater, groundwater, surface water, hospital effluent, pharma industry, and all the major Indian rivers like of south, or whether you have in the north like the Ganges, or in the Solan district, the Baddi Baroti Wala Nala, they are all high on antibiotics. And then you have, there's a high incidence of cancer among the under 50 age group. It is up by 59%. And so you need to take care of the environment compliances like the effluent treatment plant. They are mandatory if you are a bedded facility, the effluent treatment and the sewage treatment plant. The effluents need to be tested at least twice a year, and need to have, if you're a bigger hospital, the environment monitoring group. You need to be authorized by the State Pollution Control Board. For the biomedical waste authorization, you need to have for the liquid waste consent to operate and consent to establish from the State Pollution Control Board. So waste management is an important commitment of Ministry of Health and Family Welfare. And if you look at the standard precautions, whether they are hand hygiene, respiratory hygiene, safe injection practices, safe handling of soil, linens, environmental cleaning, then you have cleaning and disinfection. The waste management is given the least importance, but it is an important public health issue. So the rules and the guidelines, biomedical waste rules 2016 are there with the respective amendments are there, and they will keep on occurring. And you have the guidelines also from Central Pollution Control Board, which are available on Google. And but the whole focus, and during COVID-19 also, you had the CPCB guidelines, wherein each and every revision focused on decrease in the yellow category of waste, and there was a lot of focus on home care waste at that time also. And but if you look at, they are not only applicable during COVID-19 time, but they are applicable otherwise. They had important implication for the laboratory waste, for the nasopharyngeal swabs, and those Then whatever the guidelines, whatever the gazette notification, you need to have your own SOPs. And if you're NABH and NOBL, you need to have that SOP also in place. Now you have the Biomedical Waste Management Rules 2016, their amendments, your IC material should focus on that. These pandemics will come and go. You need to be pandemic prepared. If it is not a category A virus, keep the solid waste and the biomedical waste separate. Then you need to have a robust team. You need to have a biomedical waste management committee meetings. Segregation is done at source, collected. It is collected in the color-coded bins and bags, bar-coded. Only the laboratory waste is pre-treated. There is an intramural transportation of waste. They are transported in trolleys. They are securely tied in bags to the common waste site, and then no untreated biomedical waste is kept beyond a period of 48 hours. Now, segregation is done at source. Dead fetus below the viability. Earlier, the viability was 20 weeks. Now it is less than 24 weeks, as per the MTP bill dated 2020. Now, when you're disposing of less than 24 fetus, that is, it is non-viable, you need to dispose of at yellow category waste, and you need to have a certification by a gazetted officer or doctor on duty who's a faculty in a private hospital, signing that the fetus is below the viability period, therefore giving in yellow. Then the laboratory waste is pre-treated. Collection is when the bags are packed when 3/4 full. And then PPE, handling and transport, you need to have the appropriate PPE. Storage, now these are very well documented in the CPCB guidelines. It should be away from the public area. There should be a space allocation. 2 times, there should be a hand hygiene facility. There should be safety in pots, fire extinguisher, smoke detector, etc. Then you have deep burial, and then you have, it should be secured and locked, well ventilated. It should have a biohazard sign. It should be locked. Our waste site is huge. It has common treatment facility operators truck space also, which can come and park. It has CCTV cameras. It has barcoding also. And equipment and supplies, non-chlorinated PVC-free bags are used. And for the government facility, they are available on the GEM portal also. There's a needle cutter, and then you need to have the agreement with the common facility operator. For occupational safety, you need to have a basic health checkup, and you need to have the vaccinations also, like hepatitis B and tetanus toxoid. And if it is a pandemic like the you had during COVID times, you need to be COVID vaccinated. And if luckily India just had 19 cases, but had it been monkeypox, then you need to have the monkeypox vaccination also, that is Jenius vaccination. Then training is for all staff, those who handle biomedical waste. It could be doctors, nurses, technician, the safai karamchari or the sanitation workers. You can take help of your hand hygiene week or the antimicrobial resistance awareness activities or the Swachhta Pakhwada or the environment days activities, and be an active participant in that. And you need to have, the individual department training also. Monitoring, you can have an in-house check this for the biomedical waste management, or you can have your own app also. But this app is also, not it works when the network is proper. Then monthly report you have to share on the website as per the mandate of the biomedical waste rules 2019. And then annual report has occupier details, quantity of waste detail, the biomedical waste management committee meetings, the trainings, the health checkup, immunization, the standards of disinfection, sterilization, the liquid waste generation treatment, and maintenance of records for 5 years is also very important as per the CPCB guidelines and as per the mandate of the NABH also. The authorized person need to maintain record of the effluent, DG set, quantity of biomedical waste, logbook, register, monthly on website. Then you have the day-to-day biomedical waste register, monitoring of the records, the health checkup and immunization record, training records, the equipment records, the effluents and the DG sets, the accidents. You need to report only the major accident, that is falling of the biomedical waste truck in the water bodies or toppling of the truck. The minor accidents like the needle stick injury is not reported. So this is the barcoding, how it is done, like the color code wise. Then pre-treatment is carried out by 1 to 2% sodium hypochlorite. That is the disinfectant for half an hour, and you can have the non-chlorinated disinfectants like the Lysol or the phenol too. Now, COVID-19 biomedical waste is like any other biomedical waste. I reiterate that COVID-19 biomedical waste is like any other biomedical waste, and it is only having a double bagging and a labeling. Double bagging is to prevent spillage, and labeling is just to ensure its speedy disposal. It is like any other biomedical waste, and remember that only the used mask and tissues and toiletries by the COVID-19 patient needs to be disposed as biomedical waste. Now, if you look at the yellow category, you have the human anatomical waste, the animal anatomical waste, the paraffin tissue, infected animal carcasses, you can put in that, the soiled waste like the dressing, the plaster cuts, the cotton swabs all go in yellow category. The expired medicine go in the yellow category. The chemicals go in the yellow category. Barring the cytotoxic medicines, everything goes in yellow category. The cytotoxic medicines with the disposable will go in yellow biohazard with the cytotoxic label. Now, this is the discarded linen, mattress, beddings contaminated with blood or body fluid. Now, discarded samples, aspirates are made safe. They are pre-treated with sodium hypochlorite before mixing with other wastewater. Now, chemical liquid waste has a holding time of 8 hours. If you're using glutaraldehyde for endoscopes, they are neutralized by sodium bisulfite. OPHA, if you're using, then glycine is the neutralizer. Then you need to check the pH, dilute and drain off the endowasher fluids. Microbiology waste. Now, there's a major change happening here. The blood bags, they need pre-treatment, and then their yellow category. Blood bag, you will go, but the microbiology, if it is plastic, after autoclaving will go. Microbiology or any other laboratory waste, pathology or biochemistry, after autoclaving will go in respective category. If it is plastic, it will go in plastic, and if it is glass, it will go in glass. So you have now, this is the effluent treatment plant, how it goes, and then you need to have the material safety data sheet for the chemical so that the neutralizers are easily available. There are certain drain disposal friendly chemicals, friendly this thing, and the pH should be between 5.5 and 9.5. This is the effluent treatment reports. And so if you look at the yellow category, has the soiled category, swab states, soil swabs, soil linen, human anatomical, animal anatomical, discarded medicine, non-cytotoxic ones. Whereas the red has all the plastic disposable, including the laboratory waste. So here it is. You have everything, all the catheters, the gloves, whether nitrile or heavy duty, the PPE, which is of plastic, the shields will go in red category. All the disposable items of the ICU will go in red category. Laboratory waste, all such lab waste, whether it is a rapid antigen kit or the ELISA plate or the nasopharyngeal swab or the rapid kit or the gene expert kit, everything after pre-treatment, that is sodium hypochlorite, will go in red category. Then what category goes for autoclaving? The culture plates, the liquid culture, the solid culture. That's a log 6 reduction, the tissue culture bottle. Then you can also have the vacuumtainers. They all go for autoclaving. And then the respective category of plastic. Whereas the blood bag, again autoclaving, and then respective category of yellow only. In blood bag is an exception. So this is the sharp. All sharps cannot be mutilated. Only the simple needles from 22 to 24, 25 gauze can be mutilated. And sharp management, one needle, one syringe at a time. That's the principle. And blue is for glasswares. And all the glass articles will go in blue category. But again, so here we have vaccine vials. Vaccine vials, the glass slides, the cover slip. Glass slides and the cover slip will require pre-treatment by 1 to 2% sodium hypochlorite and then glass, whereas the vaccine vials, after 48 hours after observing the AEFI, that is the adverse effects of the vaccine, will go in this category. And syringes should be mutilated. Put the content of the cut syringes in the red bag and give it to common facility operator. So WHO recommends that all bodily fluids and solid waste of patients with monkeypox should be treated as infectious waste. So here again, the waste is segregated into biomedical waste and general solid waste. And then the biomedical waste in its respective 4 categories. And the only change is the monkeypox or the smallpox vaccine to the laboratory technicians and the waste handlers. And then in the end, I would like to say that biomedical waste management is based on the principle of circular economy. That is, if you're having a plastic, after the disinfection, that is pre-treatment of the lab waste and the treatment at the common facility level, all the plastic will go for authorized recycling. Now, Government of India has mandated that the roads which are there will have 2 to 4% of plastic. So any plastic which is non-recyclable after pre-treatment and treatment will go in the road making to increase the durability. And second is this such plastic which is recyclable goes for recycling into hangers, benches, etc. So that is known as circular economy. Nothing stays on earth, and to have the circular economy principle, you need to have the decrease in the category of waste which goes for burning. So now this is the report of the Joint Committee of the National Green Tribunal. I was part of this, like how the external of the government medical colleges or the government hospitals should be. Like apart from the biomedical waste, you need to take care of the solid waste. You need to take care of the any construction activity, that construction and demolition waste. The liquid waste also you need to take care of. Otherwise, it will cause pollution, not only because of biomedical waste, but because of water, water pollution. You can have the construction and demolition waste causing pollution. Then you can also have so many, like batteries waste, e-waste causing pollution, particulate pollution is there, burning causing pollution, and these guidelines will be out anytime. Then there are certain learning modules which are available on the Central Pollution Control Board website. Please go through that. It's easily available on Google. And so if you look at the urgent interventions we have done in terms of system capacity, greater resources, processes, rules, and guidelines, as far as the biomedical waste management is concerned. But what about the implementation of other rules which are equally important? We have done number of trainings, vaccinations, health checkup, immunization inspections we have done, equipments we have brought about, records we have maintained. In fact, this is nothing but all waste stewardship. Any amendment and the guideline, it focuses on decreasing the yellow category of waste by using non-burn technology. We need to be pandemic prepared, the COVID, whether it's COVID or monkeypox or Alaska pox, but high time we need to focus on home care waste management. Not all sharps can be mutilated. The blades, thick needles, knife and combination equipments, you just cannot mutilate them. Combination of sharp and plastic, you need to take care of them by sharp-faced. Needles with 6 fixed syringes, they will go as sharp-faced. Return back to the manufacturer, especially in cases of stapler guns or combination instrument. E-waste needs to be covered under extended producer responsibility, and we need to focus on the solid waste rules. Also, see, the gray areas in the rules will be there. Whatever is not documented, follow the international guidances, WHO Blue Book. Common biomedical waste treatment facility are not even in number. High time we need to have the third party audits. We have given our waste, but are they really, uh, really doing is as per the rules in a scientific manner? We need to have the environmental impact studies also, because our ultimate aim is green and clean hospitals under Swachh Bharat and under WHO roadmap to One Health, because Government of India is signatory to the United Nations Declaration 2030. And ultimately, waste management is the duty of all the stakeholders, whether you're inside the hospital, doctors, nurses, technicians, sanitation worker, or you're outside the hospital, the agencies, the pollution control boards, the state pollution, the Ministry of Health, the central pollution, Ministry of Environment, the pharmaceutical industry, the municipalities, and so much and so on, because we need to think from waste to wellness, integrating with the principles of reduce, reuse, recycle in the healthcare, and let the waste from the sick do not contaminate the lives of the healthy individuals. So thank you, everybody. I would now like to have an extensive discussion with you all. Any query, I would love to solve it. Yeah, I'll just go through the chat box. Yeah, any query?
Ma'am, there is no message in the chat box.
Let me see it. Wait. Yeah. Any query? Yeah, please.
They can raise
Query?
hand.
Any query? I'll be happy because I've kept an extensive discussion. I've kept an extensive discussion for the same. How to discard the samples? Samples, again, they are, pre-treated. If they are in vacutainer, best pre-treatment would be autoclaving. If they are urine sample, best would be to tie them all the, the universal containers in the red autoclavable bag or the transparent autoclavable bag, autoclave, and then dispose it of red. But if you are a small volume laboratory, in that case, hello, Dr. Sonal, if you're a small volume laboratory, in that case, you will be just putting that, all that urine sample, opening that, if you're just having 5 to 10 samples, 5 to 10 samples, just open those bottles, put equal amount of disinfectant, and you could just wait for half an hour, and you can pour off in an identified sewer, and that plastic container goes into red. Now the next question is by Dr. Pavni, that is how radiological waste are managed. Radiological means from the radiology department, so you have the lead waste there, the lead apron, the goggles are there, so they need to be given to a state pollution control board authorized recyclers. But if you're talking in terms of nuclear medicine waste, or if you're talking in terms of the sealed sources of isotope, sealed kits are there in the nuclear medicine department, then 10 times the half-life of that particular radioisotope. For example, you've taken iodine, it has 7 days shelf life, then 7 into 10 times, 70 days you need to store them in in a sealed room which has lead bricks, so that the radiation doesn't go out. And mind that all the radioisotope medicine needs to be dispersed, means when you're giving it to the patient, in a fume hood which is certified by AERB, that is Atomic Energy Board. It is to be board certified by that. Okay, any other question? Any other question? I'll be happy because I've kept discussion points. Any other, you could raise hand and you could ask. I'll be happy to answer it. Because normally wherever I go, they always say, ma'am, keep half an hour of presentation and half an hour should be discussion. So, any other? Any other, I'll be happy to answer. I could just see 2-3 questions only. We can wait for one more minute. Any other questions? Any other? I'll be happy to answer. Okay, can I ask the participants how blood bags are disposed of? Can I ask the question? There are so many participants sitting. How blood bags are disposed of? Anybody? I just covered in my lecture. It's very important. Anybody? Yeah. So you have autoclave and then yellow. Blood bags are an exception. Yeah. Any other questions? I'll be happy. Otherwise, I can ask you.
How to discard the sputum samples?
Sputum, again, if you're a high volume laboratory, then you can, it's an wide mouth container. You tighten the screw, put them in the autoclavable bag and autoclave them. Or you could just, if you're a slow volume laboratory, like 5 samples, you could just open them, put sodium hypochlorite, drain off after half an hour and put that, yeah, in, the plastic that is red, and you can drain off, identify an Indian type of toilet so that you can put that. Any other question?
Fine.
Any other? There are so many in the audience. I'm not getting any question, just 3 questions. Any other question? They're happy lot. Any question, I will be very happy to answer. Any question? How to dispose of the shoe covers? Anybody? How do you dispose of the shoe covers? Shoe covers are very thin plastic, so they will go in They will go in thin plastics, so they'll go in yellow because they increase the incineration. I'm just taking the outliers in the rule. The shoe covers will go in yellow because they are thin, non-recyclable plastics. Okay. Then how do you dispose of the paraffin blocks? How do you dispose of the paraffin blocks? They will again go in yellow category. Then how do you dispose of surgical blade? Surgical blade is also a sharp category. It won't be mutilated, so it will go as it is. Then how do you dispose of, let's say, vaccine vial? Vaccine vial is made up of glass, so after 48 hours, after observing the side effects, then only you will be disposing it off as glass. Then there's a question which has come up. Very good, Dr. Radha Kumari. And how do you dispose of masks? So any mask, whether it is single ply, double ply, triple ply, it will go in yellow category, or N95 mask, everything will go in yellow category. Yeah. Any more questions? Any more? I'll be happy to answer. Any more? Okay, then let me ask, how do you dispose of the nasopharyngeal swab which you've taken for the COVID sampling? How do you dispose of that? Anybody? Anybody? Okay, then there's a question coming up. Yeah. Nasopharyngeal swab, I would say it needs to be pre-treated. So autoclaving is best. If it is plastic, usually it is plastic only. So it goes in red bag, not yellow bag. Remember that. After, this is the major change which has come after autoclaving any lab-based. If it is plastic, it will go in plastic. If it is glass, it will go in glass. Blood stain slides, how to discard? It is, blood is a smear, so very small amount of blood. So you have then, 1 to 2% of sodium hypochlorite, put it in a jar, put the stain slides, and then after disinfection for half an hour, you put it in glass because it is made up of glass. Okay, then any more questions? I could just get 6, 7 questions. Any more questions? Any more? Any more questions? Any questions on email? Email none of you have sent. And here I would, okay, I would just see one more message. Okay, what about Harsha? Dr. Harsha Godikar has asked, what about X-ray films? So X-ray films are two categories. If you have digital ones, they are very less amount of silver, so they need to be given to State Pollution Control Board authorized recycler. If your state doesn't have it, you can go to the neighboring state. Like for example, Delhi. If Delhi doesn't have an X-ray film recycler, so we often take from UP, the State Pollution Control Board authorized recycler. You go on the website of your State Pollution Control Board and get the authorized recycler's name and address. Yeah. Any more? We could at least sort, I think, 10 queries. Any more queries? I will log off by 2:45. Okay. Any more queries? Okay, then what about cytotoxic waste? How do you discard off the cytotoxic waste? That's an outlier. I'm just discussing the outlier. How do you dispose of the cytotoxic waste? Cytotoxic waste is highly hazardous. It has ability to cause secondary neoplasias. There are reports that, you could have skin cancers, you can have bladder cancers, especially seen in healthcare workers who are giving the cytotoxic drugs without any fume hood, without any safety hood, without wearing any PPEs. So cytotoxic waste is one exception which goes to yellow biohazard, but with a cytotoxic label. Even the disposables used in the dispersal of the cytotoxic drugs, they are given in yellow bag with cytotoxic label. And this particular assembly, whether needles, syringes, gloves, they are all put, mutilated gloves, they're all put in this assembly. And this assembly is put in a plain cardboard box to prevent the needle stick injury from the needles to the bag. And so the cardboard can prevent that. Yeah. Any other queries? Any other queries? ECG electrodes, how do you dispose of? ECG electrodes, nowadays you have plastic ones and you have plastic wires, so you dispose them off in red category. But sometimes the ECG electrodes have plastic, those touch points, or you can have paper touch points which can be sheared off. The paper ones will go in yellow, the rest assembly, the plastic wire and those ECG points, they will all go in plastic category. Anything else? This is one waste forum which is silent, because wherever I go, they always request, ma'am, don't take 1 hour lecture, take like half an hour lecture, half an hour, yeah, discussion. Yeah. Any other? Okay, then let me ask, what about the goggles? Where they'll go? They'll go in red category. Okay, then what about the syringes with needles combination? Where they'll go? Syringes with needles, fixed needles, they'll go in sharp category. Okay. Any other query? Any other query? What about the combination equipments? Combination means sharp and plastic will always go in sharp category. Then what about the PPE? There are two kinds of PPE. One is plastic, that will go in the red category, and one is PPE material made up of those mask material, that will go in yellow category. So any other category? Yes. I think most of the queries I have solved. So thank you. Vaccines. Yes, vaccines is very, very important. Vaccines, they are usually made up of glass. So Dr. Ashutosh has asked me about vaccine. They are made up of glass. Normally in vaccine, we will observe for 48 hours the adverse effects of the vaccine, AEFIs, flaccid paralysis most commonly, or will observe for the vaccine effects, adverse effects. After 48 hours, you will pre-treat those glass vaccine vials, and then in glass category or the blue box, you will be putting that. The needle syringes, they are cut. The needles are in the sharp white box, and syringes are the plastics. They are in the red one. Okay. Any further queries? So I think I've taken the last query, and I'll be happy if last minute, if any query is put across. Any other query? Okay, so I just now log off. There is no more query. I think I was happy I could answer so many, queries. They were close to 10. Some I also put in. And yeah. So thank you, organizers, for having me on board, and thank you, the participants, for your patient listening. Keep on practicing waste management. It is duty of all the stakeholders. Thank you. Thank you, everybody.
Thank you, ma'am.
Thank you.
Now we have a last lecture of the day by Dr. Swapna Bopanna.
Gastroenterology and Hepatology at Action Institute of Liver and Digestive Sciences at Sri Balaji Action Medical Institute, New Delhi. Today, I'll be speaking about interpretation of hepatitis viral markers. So I'll just be giving a brief overview of the hepatitis viruses, followed by the serological profile in various parts of the illnesses. So first, the types of hepatitis viruses. So we have actually 5 important types of hepatotropic viruses, which actually infect the hepatocytes mainly. They do not have any other cells of infection in the body, human body. So the 5 types of hepatitis viruses that are commonly seen in practice are hepatitis A, hepatitis B, hepatitis C, D, and E. So in a healthy liver, when the cells are affected by hepatitis viruses or there's inflammation in the hepatocytes, then it's called as hepatitis. So hepatitis A and E are actually acute hepatitis viruses where they cause self-limiting illnesses and they last for a small time. Whereas hepatitis B and C are chronic illnesses, and these viruses can cause chronic hepatitis, leading to destruction of the liver and eventually liver cirrhosis. So first about hepatitis B. So the structure of hepatitis B is a complex structure. So, and it has several antigens that are present on the hepatitis B virus. And these antigens provide an opportunity for testing, and antibodies to these antigens are used in serological testing for these viruses. Now, the hepatitis B virus, the outer coating is called the surface antigen or the hepatitis B surface protein. The second layer that we see is actually the envelope layer, and this is characterized by the HBE protein or the HBE antigen. And the inner layer, the innermost core of the virus is formed by the core protein or what is called as HBC antigen. And within this core protein core area, we have the main genome of the virus, which is a partially double-stranded DNA. And within this DNA, there is a enzyme, which is the DNA polymerase. So these are the various proteins which make up the structure of the hepatitis B virus. And testing for these various antigens or antibodies to these proteins help us find out the phase of the disease and also help in diagnosis of the disease. So what are the various serological markers of hepatitis B? So as I mentioned, we have HBs antigen, which shows that the person is infected with hepatitis B and can be detected in both an acute hepatitis B infection and also in a chronic infection. We have anti-HBs, which shows that the person has developed immunity to hepatitis B. That is when HBsAg disappears. That is when anti-HBs antibodies arrive. Then these antibodies, if they are present in a person, it shows that the person has developed immunity to hepatitis B. We have the HBe antigen, or what we call as the hepatitis B envelope antigen. And if this is present in a person, it shows that the virus in the body is actively multiplying. And we have anti-HBe or anti-HB envelope protein, which shows that the person's immunity has responded against hepatitis B and the virus is not actively replicating. So when hepatitis B envelope antigen disappears, that's when the anti-HBe antigen is detected in the blood. And the appearance of the anti-HBe or the antibodies to HBe shows that the virus is not actively replicating anymore. Then we have the anti-HB core antibody. This shows that the person has been infected with hepatitis B. Once the person has been infected with hepatitis B, he becomes positive for anti-HB core antibody. And these antibodies, the IgG anti-HB core antibodies, generally remain for life. Then we have HBV DNA, which is measuring the viral load in the body. It measures the copies of the hepatitis B virus DNA in the blood, and the measures of the virus in the bloodstream. And this, if the virus is detected in the bloodstream, it actually means that the virus is actively multiplying within the liver. Now, how does hepatitis B get transmitted? There are 2 important modalities of transmission of hepatitis B. There are several other modalities also, but the 2 important modalities of vertical transmission, basically from mother to child, and the second is horizontal transmission. The second horizontal transmission can be because of infected needles, can be because of sharing of body fluids during blood transfusion and during tattooing and unprotected sexual intercourse. So these are the ways in which the virus gets transmitted horizontally. And vertical transmission is generally from mother to child. One of the most common causes of transmission of hepatitis B, especially in India, is horizontal transmission. Whereas in the world, there are several countries where the majority of patients who have hepatitis B because of vertical transmission. That is, the mother has passed on the hepatitis B to the child. But in India, studies have shown the transmission of hepatitis B is mainly by horizontal transmission. Now, outcome of hepatitis B virus infection by age at infection. This is an important thing because the age at which a person gets infected by the hepatitis B virus is important in maintaining the chronicity of the virus. For example, if the virus is there within an infant or within a child, if the virus has infected the liver at infancy or early childhood, the chances of having a chronic infection are high. This is because the immune system of the child or the immune system of the infant is not strong enough to fight off the virus and clear the virus from the liver. So therefore, at birth, the people who are infected with the virus, the chances of chronicity are higher, but the chances of symptomatic infection in these patients are not there. Therefore, somebody in childhood infected with the hepatitis B virus may not show any symptoms at all. Whereas, if you look at if the people who get infected at a later age, the proportion of patients who develop symptoms are higher. This means that if an adult is infected with hepatitis B, the proportion of adults who will show symptoms like jaundice are higher, and the chances of chronicity in adults are lesser. So the later in life that you get infected, the chances of developing a chronic infection are lower, but the chances of developing symptoms are higher. Whereas in children and in infants, the chances of symptoms are very less, and therefore they easily go undetected. And these are the patients in whom chronic infection develops. This is because of a nascent immune system which is unable to clear the virus, especially underdeveloped immune system in children and infants. Now, what are the stages of chronic hepatitis B? So these stages generally are seen in patients or in people who have acquired the virus perinatally and not by vertical transmission. So there are four important stages of chronic hepatitis B. So the first stage is called as the immune tolerance phase. The second phase is called the immune clearance. Third is a low replicative phase, and the fourth is what is called as a reactivation phase. So just to explain, immune tolerance means the body tolerates the replication of the virus. This generally occurs when the immune system is young or immune system is nascent, as I explained, especially in children and infants. So there you will have an actively replicating virus, and therefore the HB antigen will be positive. The HBV DNA copies in the blood will be high. But the immune system is not active, and therefore the ALT levels, that is the aspartate aminotransferase levels in the body, aspartate and alanine aminotransferase levels in the body, they remain low because the hepatocyte destruction is low. This happens because the immune system is not actively attacking the hepatocytes. Then you have normal, and in these patients you have normal or mild chronic hepatitis. And these patients generally, when they have an immune tolerance phase, they are HBe positive and they have chronic hepatitis, and therefore these patients are labeled as HBe positive chronic hepatitis. Now then, following the immune tolerance phase, the body starts recognizing the virus and tries to clear the virus from the body. And in these patients, they enter a phase that is known as the immune clearance phase. In the immune clearance phase, the HBe positivity slowly starts turning into HBe negativity. That is, the immune system starts attacking the virus and reduces the viral replication. And therefore, you can see the DNA copies start reducing as the immune clearance phase starts. But when the immune clearance starts, the immune system not only destroys the virus, but also destroys the hepatocytes in the body. And this leads to an increased elevation of ALT and AST. And these are the patients who actually have chronic hepatitis in moderate or severe forms. And these are the patients who would in future go on to develop a chronic liver disease or chronic liver injury, and therefore cirrhosis. So when the immune system starts clearing the virus, there is destruction of the hepatocytes, which in turn will lead to liver injury and therefore liver cirrhosis. Once the immune system has actively removed a lot of virus from the body, the virus enters into a stage of low replication, and this is the phase when we start seeing the anti-HB antibodies coming in the blood, which means that the virus has reduced its replication and it's not replicating. And in this phase, because the immune system then also goes into an inactive state, you can see that the ALT levels start normalizing in this phase. And in these patients, you can have some hepatitis and some destruction in the liver because the virus is still replicating at a low levels. And this phase is actually called as the inactive carrier state. So once a patient has entered the inactive carrier state, it just means that the immune system has been able to control the virus, and therefore of liver injury and liver cirrhosis in this group of patients who are in an inactive carrier state is very low, and therefore we generally do not treat patients who have already entered an immune carrier or inactive carrier state. And some of these patients who enter an inactive carrier state later in life may reactivate, the virus may reactivate, which can lead to again destruction of hepatocytes, and these are the patients who can then have liver injury and cirrhosis. And these patients are generally HBe negative chronic hepatitis. That's what we call them when they are in the reactivation phase. So these are the various stages in which the chronic hepatitis B occurs in a patient, and a patient goes through these different stages. Now, what are the outcomes of hepatitis B? In an adult HBV infection, around 5% of patients can develop chronic infection. And some of them will enter an inactive carrier state, and some of them will enter a chronic active hepatitis state. In patients who develop chronic hepatitis, up to 15% of patients develop cirrhosis, and up to 5% of these patients develop liver failure or liver cancer. In adult HBV infection, around 95% of the patients clear the virus, and in these patients, HBV infection is considered to be resolved. Now, acute hepatitis B infection with recovery, what is the typical serological course that we see? So once a patient has acute hepatitis B, the infection resolves in 95% of the patient, but in 5% of the patients, there is chronic infection. So as I said, adult HBV infection generally becomes symptomatic, but the chances of chronicity are low, whereas it is completely opposite in childhood HBV infections, where the chances of chronic infection are high, and the chances of infection resolution are low, and therefore when children get infected with hepatitis B, they generally go on to develop silent chronic hepatitis. Now, acute hepatitis B infection with recovery, the typical serological course that we see in adults is they develop symptoms. Then they are initially HB antigen positive, which means that the virus is actively replicating, and soon they will become anti-HBe negative when the virus stops replicating. Now, the HBsAg starts rising as the patient is infected within the first 3 to 4 weeks, and then HBsAg is detectable. This is an adult infection that we're talking about, where generally adults have symptomatic infection, and therefore acute hepatitis B infections are common in adults. Whenever hepatitis B is seen in adults, it's an acute hepatitis B that is presenting with symptoms rather than chronic hepatitis B. And second, you can see that the IgM anti-HBC or the IgM anti-HB core antibody starts rising in the blood early on in the infection and then goes on to settle. The hepatitis B surface antigen continues to rise and then fall and then completely disappears by the end of 6 months. Now, once HBsAg is completely gone from the blood, there is a window period in between before anti-HBs can rise and provide immunity. And this is the window period that's actually important serologically, where HBsAg may be negative, anti-HBs may also be negative. But the way to detect patients in this window period is to test for IgM anti-HBC. And if IgM anti-HBC is positive, then that patient can be labeled as acute hepatitis B. This is especially important in blood banks where there is no HBs in the blood, there is no anti-HBs in the blood, but still the blood that is collected from the donor may be positive for hepatitis B. And it is the core antibody that can tell us whether a person has been infected with hepatitis B. Now, to divide the serological phases of acute hepatitis B, we have the early phase, we have the window phase, and we have something called as a recovery phase. So, what is the combination of serological markers that we see in early phase? In the early phase, we see HBsAg, which is positive. HBe antigen will be positive. This is because the virus is actively replicating in the early phase of acute hepatitis B. The IgM anti-HB core antibody is positive, and the HBV DNA are in high numbers, especially because you can see here the virus is replicating, and therefore the DNA levels in the blood are high. Now, when you enter the window phase, as I mentioned, the window phase is when the hepatitis B surface antigen has completely disappeared, and it is during this window phase the HBe antigen also has become negative, and the window phase does not show anti-HBs or anti-HBe antibody because they are yet to appear. So these both antigens have disappeared from the blood, but these antibodies have still not appeared. And then in this phase, the way to detect the patients in the window phase is to look at IgM anti-HB core antibody or HBV DNA levels. Now, acute hepatitis B infection in the recovery phase. How do we detect these patients? So in the recovery phase, of course, the antigens for hepatitis B, like surface antigen or envelope antigen, are negative, and anti-HB core antibody is also negative. Now, in the recovery phase, you will see that the IgG anti-HB core antibody is positive, and anti-HBs antibody is positive, and anti-HBe antibody is positive. Now, HBV DNA occurs in very low levels, and this can be either positive or negative. And in recovery phase, sometimes you have very low levels of hepatitis B DNA, and therefore in the recovery phase sometimes you may still find HBV DNA positivity. But the important thing to note about the recovery phase after acute hepatitis B is the appearance of the anti-HBs antibody, which makes the patient non-transmitting. That is, the patient with an anti-HBs antibody generally does not transmit the infection to another person. So now coming to chronic hepatitis B, a little about chronic hepatitis B. As I mentioned, that the acute phase lasts for 6 months in hepatitis B, and the chronic phase comes after 6 months. So in the chronic phase, the patients will be positive for HBsAg, but IgM anti-HBc will soon disappear. That is, at the end of 36 weeks or 38 weeks after the initial infection, IgM anti-HBc completely disappears, but total anti-HBc may be positive throughout the infection. And in fact, any person who's ever been infected with hepatitis B will have total anti-HBc positive. So if IgM anti-HB core antibody is negative and total anti-HB core antibody is positive, it means that most of these core antibodies are IgG antibodies. So in a patient with chronic hepatitis B, the patient will be positive for HBsAg, will be positive for total anti-HBc, and may or may not be positive for HBe antigen, because that depends on the phases: immune clearance, immune tolerance, reactivation, and the phases that I earlier described. So it depends on which phase the patient is currently in. But definitely patients with chronic hepatitis B will be positive for HBsAg and total anti-HBc antibodies. Now, to divide serologically, we can divide chronic hepatitis B into the non-replicative phase, the replicative phase, and a replicative pre-core or a core mutant virus phase. So if you want to look at what the replicative phase during chronic hepatitis B, the surface antigen is positive, because surface antigen is positive in all these patients with chronic hepatitis B, and so are IgG anti-HBc antibodies. And therefore, what we generally do is measure the total anti-HBc antibodies, and total anti-HBc antibodies will be positive in any form of chronic hepatitis B. But in the non-replicative phase, HBe antigen will be negative and anti-HBe antibody will be positive. HBV DNA is generally, because it's a non-replicative phase, they are in low levels. And this non-replicative phase is generally what we see in inactive hepatitis B carriers, just like I showed in the previous graph. So when the virus is completely non-replicative and there is no liver injury going on and the DNA levels are very low in the body, such patients are generally termed as inactive carriers, and we don't need to treat these patients. The chances of liver injury and progression to liver cirrhosis is very low in these patients. Now, when we come to the replicative phase, so of course in chronic hepatitis B, both HBsAg and IgG anti-HB core antibodies will be positive. In a replicative phase in chronic hepatitis B, the IgM will be negative. So if you look at the total anti-HB core antibody, it will still be positive in chronic hepatitis B. But in the replicative phase, you will see that the E antigen is positive and the HBV DNA is high. Now, this replicative phase is generally seen in what we call as the immune tolerant phase. And in the immune tolerant phase, you generally have patients who are immune tolerant, and this generally occurs in young children or in the teenage years. So what about the third form of serological chronic hepatitis B? So the third form that we generally have to treat because there is ongoing liver injury and the low levels of liver injury are there. That is when the E antigen is negative. This happens because there is mutation in the virus. As the virus undergoes immune clearance, the virus starts developing mechanisms to resist the immune system of the body. And one of them is under immune pressure, it loses its E antigen. And this does not mean that the virus is not replicating. Sometimes the loss of E antigen, especially in hepatitis B, in this phase, if there's a pre-core or a core mutant, then the E antigen is negative. Of course, because chronic hepatitis B, you will have HBs and IgG anti-HB core antibody positive, as I mentioned. And in these patients, you will also have anti-HBe antibody positive, but HBV DNA will be on the higher levels. And this HBV DNA is how we come to a conclusion that this E antigen negativity is due to mutation and not due to a replicative phase, because generally when you have HBe antigen negative, you should have HBV DNA at very low levels, because E antigen represents replication, and when it is negative, DNA should be low. Now, serology in an immune person. So if you have a person who's been vaccinated or a person who's had previous infection, how do you differentiate these two? So HBsAg will be negative in both. The anti-HBs antibody will be positive in both if you have taken a vaccine or if you have had an infection before. But the way to differentiate them is to measure the hepatitis B core antigen antibodies, that is IgG anti-HBc or total anti-HBc will be positive in a natural infection, whereas in vaccinated individuals, the core antibody will be negative. So this testing of anti-HB core is very important, especially in areas like India, which is an endemic area for hepatitis B. So if past recovery of HBV infection, that is anti-HBs titers are low, then it is that means that there's past infection, or it can also happen in acute HBV infection during a window period. And it has a significance mainly in organ donation and blood donation, especially to recognize the window period where HBs antigen has disappeared, but anti-HBs antibodies have not yet appeared. So another important test that hepatitis B that we do is DNA quantification, and it's done by real-time PCR. So it helps us to find out when to initiate treatment. So if there's a wild type virus, we initiate treatment when the copies are more than 20,000 international units per ml. Whereas if there is a pre-core mutant, then even more than 2,000 we have to treat. Then we use it to monitor patients, the response to treatment, especially in patients with pre-core mutation. We have to keep doing the DNA levels because that's the only way to find out if the patient is responding to treatment. And we also use DNA to find out reactivation of a patient who's already in a non-replicative phase. Suddenly the patient starts developing symptoms. Then we do a HBV DNA levels to find out if there's reactivation, and also to diagnose patients with HBV infection and fulminant hepatic failure. Now, there are several genotypes of hepatitis B, and in India, the most common genotypes are A and D. The testing for genotypes is not generally done in routine clinical practice, and this is also done by PCR testing. And the significance of genotype actually was earlier, but now because of antiviral drugs that are available, this testing for genotypes is not routinely done. Now, quantification of HBsAg is very routinely done in many labs, and this HBs concentration is basically, it shows the levels of intrahepatic CCC DNA, and the amount of circulating HBsAg is an indirect marker of control of infection and a surrogate marker for the number of infected cells in the body, that is hepatocytes. The HBs titers are higher in immune tolerance phase than in immune clearance phase. And there are various ways of testing this HBS antigen. So how does it help us? It helps us identify the risk of reactivation. Because there are very high levels of HBs AgE antigen means that the patient may have high chances of reactivation and going into a replicative phase from a non-replicative phase. Then it helps us to find out the stage of fibrosis, the risk of developing HCC, and also to decide the duration of treatment, especially when patients are in nucleotide analogs. Now, coming quickly to the other hepatitis viruses, we have the hepatitis D virus infection, and this virus is hardly seen in India, and it requires the presence of a concomitant HBV infection, and diagnostic marker for this is IgM anti-HDV. Now, hepatitis C is again a virus which causes chronic hepatitis. So, the acute HCV infection, generally, most patients with hepatitis C infection are progress to chronic hepatitis. So in the early phases of infection, the HCV RNAs are high, but later on they stabilize, and the ALT levels, that is the liver enzyme levels, generally stabilize in chronic hepatitis C. But one thing that will be always positive in patients with chronic hepatitis C is anti-HCV, which will always be present, and HCV RNA will be present in most cases, 90% of the cases. So only 15 to 25% of HCV infected persons clear the virus. Therefore, most patients, that is 75 to 85% of patients who are infected, will develop chronic hepatitis C. The easiest way to diagnose chronic hepatitis C is to do a HCV antibody test and then later confirm it by doing a HCV RNA test, either by PCR or an RNA detection test. And then we do a HCV genotype test where necessary. Now, because of the high mutation rate, that is, the viruses inherently has a high mutation rate, and therefore HCV genotypes were initially tested. And HCV genotypes help us to find out the type of therapy, the duration of therapy, and the response to therapy. But due to the new drugs that are available nowadays, genotyping of the virus is generally not necessary these days because the drugs that are available have a pan-genotypic effect, and they do not influence our treatment decisions anymore. And therefore, you will see that the testing for HCV genotype has slowly been given up now. So IgM, HAV is another virus. Hepatitis A and hepatitis E are viruses which cause acute self-limiting hepatitis most of the times. They're very common in India and they're transmitted by a fecal-oral route. So the marker of acute hepatitis A is IgM anti-HAV. And when IgM anti-HAV is positive in a patient who has clinical jaundice and lab parameters suggestive of hepatitis, means that they have acute hepatitis A. And if you want to find out if a patient has already developed hepatitis A in the past, then you will test for total anti-HAV antibodies or IgG anti-HAV antibodies. So typical scenario is the initial symptoms are present, the liver enzymes are very high in thousands, and IgM anti-HAV will be positive, which slowly becomes negative over a period of 5 to 6 months. And past infection can be detected by measuring total anti-HAV antibodies in the patient. Now, acute hepatitis E is very common, and it's one of the most common causes of hepatitis in India. And hepatitis E virus is detected by testing antibodies, that is IgM antibodies to hepatitis E virus. And a typical serological course looks like this. When the patient has symptoms, the enzymes are very high, the liver enzymes are very high. And the way of diagnosing acute hepatitis E is to measure the IgM anti-HEV levels. And this is what we clinically use to detect a person who has acute hepatitis E infection, especially in a person who presents with symptoms like jaundice. So that is it, an overview of hepatitis, acute hepatitis and chronic hepatitis. If you have any questions, I'll be glad to take it. Thank you.
So with this, we come to an end of day 6. Tomorrow we will again start at 9 a.m. Thank you.